vibrant society of India, FOGSI, Pune Obstetric and Gynecological Society, to bring this, a beautiful workshop in association with AICC West Zone RCOG on enhancing infertility. I thank, along with my entire team, to Dr. Sarita Bhalera, Chairperson West Zone, and immediate Chairperson Dr. Amit Patki, both my very dear friends. When I gave a call to them, in a fraction of a second, they said, "Of course, Sunita, anything for fertility and anything for POGS and anything for you." I thank both of you for making this wonderful workshop. I thank Pooja Loda, my joint clinical secretary, who has taken huge efforts with these two to bring in the great infertility consultants from across the globe. Friends, the topics they have chosen are most practical and have been handpicked to cater to our day-to-day infertility practice. We all know that RCOG always has been on the helm of academic excellence, and today it's not exception. So sit back, relax, and absorb and expertise and excel in your day-to-day practice. Thank you, friends.
Thank you so much, Sunita. For her, I have one comment. Yes. We must say that your smile is a reason for many others to smile. Welcome everybody to the workshop, and I now request Dr. Sarita Bhalera, who is our chairperson of the AICC RCOG West Zone, to give her welcome address.
Ma'am is joining. She's having some trouble with the connection. She'll be joining us in the next couple of minutes.
Okay.
Meanwhile, Sabrina, I just want to thank Dr. Vaijayanti Patwardhan. She is our MMC observer and she has joined us. So I welcome her on behalf of POGS and thank you. Sabrina, you are muted.
I said hello to Vaijayanti. Great to have you on our workshop. So friends, limits exist only in our minds. As you can see since morning, we've had this very fantastic vision of our president and this amazing conference going virtually with more than 3,000 people logged in. I think that we must have created an absolute record by now. This is indeed going to be a star workshop because we have got amazing international and national speakers. And enhancing success in infertility is a topic which is of great interest to everybody and not just to people who work with infertility. Even our day-to-day gynec practice, at least 20% comprises our infertility patients. So has Dr. Sarita managed to knock in? Dominic?
No, ma'am. I'm just talking to her. She'll connect.
Hello.
Hi, I'm Dr. Sangeeta Agrawal here.
Yes. So our chairpersons for the first session are Dr. Sangeeta Agarwal, and she is a consultant with many hospitals in Mumbai, and her special interest lies in PCOS, reproductive endocrinology, contraception. We also have Dr. Sudeshna Rai, who is a committee member and Indian representative of the AICC RCOG West Zone, who has a special interest in robotics and endoscopy, and Dr. Latika Chawla, who is an obstetrician and gynec endoscopic surgeon at Women's Hospital, Khar. So, Sangeeta, your comments?
Sabrina Bokal, thank you very much for your kind words. I just want to inform that there is a slight change in the program. I think Sarita is having some difficulty in logging in. So I will start off with the first session. And that is the first speaker for the day, Dr. Adam Balan. And yes. Before I introduce him, I want to congratulate the Pune Obstetric Society for a wonderful program. and it is a great initiative to have this joint session with AICC RCOG West Zone, where Dr. Sarita Bhalerao is the chairperson and Amit is the immediate past chairperson. So congratulations all for a fantastic program. And it is my pleasure to introduce Dr. Adam Ballan. So may I have his introduction slide, please?
Sangeeta, you can just say a few words about him and then we'll start with his lecture.
Yes, but I need the intros on the screen.
Okay, so Dr. Adam Ballan is a professor of reproductive medicine and surgery at Leeds Teaching Hospital in the UK. He has been the former chair of the British Fertility Society and authored many texts on PCOS. Dr. Ballan will be talking on an update on infertility in women with PCOS. So we'll begin with his talk right away.
Thank you very much for asking me to talk to you today. My name's Adam Ballan. I'm a professor of reproductive medicine in Leeds in the UK, and I've been asked to talk to you about the management of anovulatory polycystic ovary syndrome. I have no specific disclosures. And the plan today is to understand polycystic ovary syndrome, but particularly within the context of infertility and ovulation induction therapies. So you'll be very familiar with polycystic ovary syndrome, which covers a huge spectrum of signs and symptoms, the main features being those of androgen excess, either biochemical or the physical manifestations as listed here, some form of menstrual cycle disturbance, and also the presence of polycystic ovaries. There are also a large number of clinical associations, in particular metabolic problems with increased risk of type 2 diabetes and other problems associated with obesity, and of course in the context of today's talk, subfertility, associated with the erratic menstrual cycle, but also, of course, the other components of polycystic ovary syndrome, which lead to abnormal ovarian function. There have been a number of consensus meetings over the last few years. I've been privileged to have been a part of all of these consensus groups, and I list here the various publications that have arisen from them. The latest being in 2016, which was the WHO guideline for the management of infertility, which I was responsible for. And this then fed into the 2018 international consensus, the Centre for Research Excellence in Polycystic Ovary Syndrome global guideline that was simultaneously published in these three key journals. So this was the International PCOS Network, incorporating a large number of organizations across the world, not only obstetrics and gynecology organizations, but also importantly patient support groups as well. So these were the three main publications that came out of this consensus group. And we agreed once more that the Rotterdam criteria, the joint ASRM-ESHRE criteria for the diagnosis of polycystic ovary syndrome, are still appropriate to this day. And that is the presence of the presence of 2 out of the 3 listed criteria. Some form of menstrual cycle disturbance, evidence of androgen excess, and or the presence of polycystic ovaries, once appropriate investigations have been performed to ensure that there are no other causes of menstrual cycle disturbance or androgen excess. So briefly, the other causes of anovulation can be grouped into those associated with ovarian insufficiency, in which gonadotrophins will be elevated, or those problems at the level of the hypothalamus and pituitary, in which case gonadotrophins will be suppressed. And in all causes other than polycystic ovary syndrome, estrogen levels are also usually low. Polycystic ovary syndrome is notable for the huge variation that one can see with respect to gonadotrophin levels. FSH is usually normal, LH is most often normal but can be elevated, and estrogen levels are also normal. Androgen excess can simply be measured by checking serum testosterone concentrations. It's reasonable to measure sex hormone binding globulin, which is the carrier protein for testosterone, which will be suppressed when there is hyperinsulinemia secondary to obesity, and this will enable you to calculate the free androgen index. Other androgens we don't measure in routine practice, particularly in the UK, where conditions such as late onset congenital adrenal hyperplasia are uncommon. But certainly if the testosterone is significantly elevated, then one should consider measuring adrenal androgens as well, to exclude these other causes of androgen excess, namely late onset CAH and the rare androgen secreting tumours, which may present with a relatively short history of problems such as hirsutism, which can be another pointer to the diagnosis. And Cushing syndrome, which is an insidious onset and also uncommon in young women of reproductive years, who of course we're dealing with in the context of subfertility. Then we have to think about how we define the polycystic ovary. 100 years ago, Stein and Leventhal were looking at ovaries at laparotomy, and these are some very historic slides here when a wedge resection involved removing up to 75% of an ovary, but it did give us some beautiful slides to illustrate the morphology of the polycystic ovary at laparotomy and histological cross-section. But of course, this would not be done these days, and instead we use ultrasound. At the time of Rotterdam, I published a paper that indicated that a polycystic ovary should have at least 12 of these small immature egg-containing follicles between 2 and 9 millimeters in diameter. But over the last 20 years, with the advent of more high-tech ultrasound machinery, we now recognize that a polycystic ovary has to have at least 20 small follicles per ovary, and ovarian volume is usually enlarged as well. Remember, of course, here we're seeing a two-dimensional picture, but the ovary, of course, is three-dimensional, and it's important to scan carefully both ovaries. A measurement of anti-Müllerian hormone is associated with the small follicles, particularly those between 2 and 5 millimeters in diameter. And it's been shown in many studies now that women with polycystic ovaries have an elevated serum AMH concentration. This is a study from our unit in which you can clearly see differences between those with normal ovaries, polycystic ovaries and regular cycles, and polycystic ovary syndrome. In other words, polycystic ovaries and symptoms. And these were our cutoffs using our patients, but there isn't yet an international consensus agreement for the cutoff of the polycystic ovary, or for that matter, polycystic ovary syndrome. Remember also that when doing an ultrasound scan, we should look at endometrial thickness, because the unopposed estrogen in the woman with anovulatory PCOS can lead to endometrial hyperplasia and over time endometrial adenocarcinoma, and therefore it is absolutely vital to ensure that young women with polycystic ovary syndrome are provided with something to protect their endometrium, whether that's the cyclical use of the combined oral contraceptive pill, progestogens alone, or a progestogen secreting intrauterine system to protect the endometrium until fertility is required. So the polycystic ovary overproduces androgens, predominantly testosterone, leading to the signs of androgen excess and menstrual cycle disturbance. And testosterone is stimulated by luteinizing hormone, particularly in those women who are slim. But we no longer consider an elevated luteinizing hormone to be mandatory for making the diagnosis of polycystic ovary syndrome. Neither are we interested in LH to FSH ratios, as they are not particularly helpful. But an elevated LH may help predict the outcome of fertility therapy. For example, those women treated with clomiphene who have persistently elevated LH do less well, and those slim women with an elevated LH tend to do better when offered ovarian diathermy. In those women who are overweight, hyperinsulinemia suppresses SHBG, acts as a cogonadotrophin, amplifying the production of testosterone by the ovaries. And it's been clearly shown by ourselves and a number of other groups that the more overweight a woman with PCOS, the higher her serum insulin concentrations, the worse her symptoms and endocrine disturbance. And if she can lose weight, we would expect to see a significant improvement, not necessarily a complete reversal of all of the symptoms, but certainly an improvement, and more importantly, in the context of fertility treatment, and improved response to ovulation induction and a better outcome of fertility treatment. Being overweight is common in women with PCOS. Central adiposity is key and is associated with metabolic disturbance. So this woman here has a BMI of 35, as does the woman in the middle, but the woman on the right has this visceral fat, visceral adiposity associated with metabolic problems. And this woman in the middle has subcutaneous adiposity. She may also have metabolic problems, and we know that the subcutaneous fat is also metabolically active, but she is likely to have fewer problems than the woman on the right. We also see big variations in different ethnic groups, and in Leeds we've done a lot of research over the years looking at our South Asian population, both in the UK and also with colleagues in collaboration in Sri Lanka. And we find that South Asians have increased insulin resistance and a worse phenotype at a lower body mass index and younger age than white European women with polycystic ovary syndrome, and the South Asian women have a greater degree of central adiposity correlating with insulin resistance. We also see other differences, for example, in folate metabolism, leading to increased cardiovascular and reproductive risks, and we see a worse outcome following fertility treatment such as IVF. Time doesn't allow me to go into detail about that today, but it's quite an interesting situation. So coming on to the management of anovulatory polycystic ovary syndrome, and I'm going to present the algorithm that I put together for the WHO guideline. So we diagnose PCOS by the Rotterdam criteria. Some women with PCOS have regular periods and may well be ovulating and can conceive naturally. And so they should be given a chance to conceive naturally, but also it would be reasonable to consider full fertility investigations just to make sure there are no other problems going on. So the standard investigations in the woman, not only the endocrine profile and ultrasound scan that I've already mentioned, but of course an assessment of thyroid function, vitamin D status, screening for diabetes. I believe in an assessment of tubal patency before starting ovulation induction, and of course assessment of the male partner as well, and advising appropriate lifestyle and vitamin supplements. There's quite a lot of debate around the world really as to whether there should be a cutoff weight or BMI before starting any treatment, because we know those women who are overweight not only have a reduced chance of conception, they have an increased risk of miscarriage, an increased rate of congenital anomalies and obstetrical problems as well. So in the UK, we prefer not to treat in those who have a BMI of greater than 35, and preferably for younger women with more time on their sides, they should get their BMI down to less than 30. This is in a European cohort, and of course we know that in the South Asian population, BMI levels need to be adjusted downwards as well. Lifestyle management is the best approach, but it's difficult to maintain long term, and there are a few randomized trials. There's certainly no evidence for a specific PCOS diet, although a lot written about different diets for women with PCOS, and essentially keeping carbohydrates down is probably a good idea. Giving metformin probably has little effect in achieving weight reduction, and for those with extreme obesity, bariatric surgery, that is gastric banding or bypass, may be helpful. But in those in whom we do provide gastric banding, there can be very rapid weight reduction, and it's important not to try to conceive until metabolic stability has been achieved. The latest PCOS guideline go into quite a lot of detail about lifestyle behaviors, and particularly focusing on psychological factors and support from counselors and reproductive nutritionists to optimize the outcome. I mentioned inositols briefly because these have become popular, but there isn't any real hard evidence for improving metabolic parameters or reproductive outcome. Possibly the combination of myo-inositol and D-chiroinositol may be beneficial, but again, more data really is required. Similarly, with respect to this list of antioxidants and vitamins, all of which have become popular, but none of which have been shown to significantly improve reproductive outcome. So, having performed full investigations, assessed lifestyle, ovulation may well start happening for those who lose weight, but if not, we have to proceed to ovulation induction with either letrozole or clomiphene citrate as first-line therapy. And the challenge here is to stimulate the development of a single follicle from the many follicles that are present in the polycystic ovary. And we no longer feel that clomiphene is the first-line therapy, although it had been for many years, and in fairness works well. We tend to use a low dose, monitor with ultrasound, measure LH on day 8, because those with an elevated LH on day 8 do less well. This is old data now from Steve Franks' group in London, illustrating a progressive cumulative chance of conception over time. So it's worthwhile persevering with treatment. Clomiphene acts as an anti-estrogen at the level of the pituitary and also at the endometrium. It encourages pituitary production of both FSH and LH, but there is the anti-estrogenic effect on the endometrium and also an absence of feedback from the ovary to the pituitary, thereby leading to high levels of FSH and LH that can in turn be detrimental, not least of which by increasing the risk of multiple pregnancy. Letrozole, on the other hand, is an aromatase inhibitor that acts at the level of the ovary, inhibiting the conversion of testosterone to estradiol. Feedback to the pituitary is still facilitated, and therefore levels of FSH and LH tend to be lower, and therefore you are potentially more likely to have a monofollicular response. There's no adverse effect on the endometrium, and there's quite a short half-life with letrozole as well, which is also beneficial if there are any concerns about teratogenicity, which seem to be unfounded. The Cochrane database clearly shows that when compared with clomiphene, the odds of having a live birth are significantly improved with letrozole. Miscarriage and multiple pregnancy rates were similar in this Cochrane review. I'd like to touch upon the use of metformin for women with PCOS. There's a huge amount of interest in metformin, and many studies are still ongoing. We performed one of the largest RCTs back in 2006 in which overweight women with PCOS were randomized to receive either metformin or placebo over 6 months. And we found no difference in the rate of ovulation between the two groups, but those women who lost weight in either group were those who were more likely to ovulate. Rick LeGros performed a large study in North America looking at the chance of a live birth with clomiphene alone versus metformin or the two combined, and found that clomiphene was superior to metformin and that the combination provided no advantage in achieving a live birth. And here we can see the cumulative chance of conception of the combination clomiphene alone and metformin over time. We have been responsible for the Cochrane database and have performed a number of systematic reviews. Back in 2012, the consensus was that there was no evidence of benefit for improving live birth rates with metformin, although our latest iteration, published just over a year ago, showed limited evidence in improving live birth alone and against clomiphene for those with a low BMI. So this is metformin versus placebo. We split it into BMI groups less than 30 and greater than 30. And you can see here this only just reaches significance when all are combined. Similarly, when compared against clomiphene, for those with a BMI of less than 30, it just reaches significance. But for the whole group itself, there is no evidence of benefit. So at best, metformin may have a mild benefit. And when combined with clomiphene in this latest iteration of the Cochrane review, we see no benefit. So really, second-line therapy is either gonadotrophin or ovarian diathermy. With gonadotrophin therapy, it's daily injection, so we have to start with a low dose, monitor very carefully with ultrasound, and have very strict criteria for the administration of HCG, which gives the pre-ovulatory trigger, to ensure that we minimize the risk of multiple pregnancy. So we only allow one follicle of greater than 17 millimeters and no more than a total of 2 greater than 14 millimeters. And again, this is an old study of women who did not ovulate in response to clomiphene, illustrating good cumulative chance of conception over time. The alternative is ovarian diathermy, and it's important not to pepper pot the ovary, but to use minimal dose diathermy to achieve the desired effect. This leads to unifollicular ovulation, so there's no risk of multiple pregnancy or ovarian hyperstimulation syndrome. You can check tubal patency at the same time, and it may be more cost-effective than the use of gonadotrophins. But there are the risks of surgery, potential risk of adhesion formation, and the destruction of normal ovarian tissue. So it's very important to ensure that a low dose is used. This is one of the largest studies that has been performed, randomizing clomiphene-resistant women to either diathermy or recombinant FSH. And you can see that the 12-month cumulative conception rate was similar in the two arms. However, after 8 weeks in those who had diathermy, 45 required clomiphene, and then another 21 required recombinant FSH. So you can see here that after 6 cycles of recombinant FSH, the cumulative chance of having a baby was double that in the ovarian diathermy arm. But by 12 months, when none of these patients received additional therapy, so the cumulative conception rate remained the same. The cumulative conception rate was only equivalent because of the pragmatic approach to using additional clomiphene and gonadotrophins. So last, if none of these has worked, then we move on to IVF treatment, and we have to use protocols that minimize the risk of ovarian hyperstimulation syndrome. I don't have time to go into IVF protocols for women with PCOS, but essentially a GnRH antagonist protocol is what we tend to use, potentially also with a GnRH agonist as the pre-ovulatory trigger to minimize the risk of ovarian hyperstimulation. And increasingly now we may electively cryopreserve all embryos and do a frozen embryo replacement cycle at a later date once the ovaries have settled down. So that has given you a brief overview of how we manage anovulatory PCOS. And I'd just like to leave you with the details of the PCOS patient support group here in the UK, where patients can access useful and reliable information on all aspects of PCOS. Thank you for your attention.
So that was a very fantastic talk by one of the stalwarts, Dr. Adam Balin. It is said that the stars are the landmarks of the universe, and truly we've had a landmark lecture from the master. And I would like to invite comments from our chairpersons. Dr. Sangeeta, over to you.
Thank you, Dr. Bokal. Thank you, Dr. Balin. That was an excellent presentation, a fantastic synopsis on PCOS diagnosis and the treatments that we have right up to going up to IVF. So you presented the guidelines, which is very, very useful. And it is quite interesting to note that all those other N-cysteine, biotin, etc., the myoinositols and D-chiroinositols, that there is no evidence to support their success. And we'll now take some questions from the audience, if there are any. So I'll request Sagar and Pooja to send the questions if there are any. Meanwhile,
what I would like to ask is Dr. Latika Chawla there? Has she joined us? Our chairperson, Latika, are you around?
Yeah.
Yes, Latika. Hello.
Hi, madam. Can you hear me?
Hi. Yeah, I can hear you now. Yeah. So, what are your comments on laparoscopic ovarian drilling after hearing his talk?
So, ma'am, in our kind of a setup, we're generally moving away from laparoscopic ovarian drilling. We're not doing much of it these days. Most of our IVF consultants that we refer our patients to are strongly against laparoscopic ovarian drilling. We see that it does bring down the AMH significantly, and they are not comfortable doing drilling as a primary method for resistant patients.
Right.
So addition of myoinositol is what is generally recommended by our specialist. I mean, I don't remember the last time we did an ovarian drilling. It's been over at least 1.5 years that we would have done that. But
true. I know how things have changed. Like we have probably just moved away from surgery onto completely hormonal therapy.
Absolutely.
Right. Yes. Dr. Sangeeta, your comments on what he said about not actually treating people with infertility until their BMI comes to below 30. So what are your thoughts about that?
so how much ever I may agree with him, but we all know, we all see our patients in our clinic, and they have PCOS. They are obese, but they are willing to do anything to get pregnant. And you know, if you tell them that okay, you need to go and lose weight and come back, you realize that sometimes it just doesn't work, and they are very keen to start the treatment. So I think every doctor needs to have a fine balance between both approaches. We encourage, we counsel our patients to lose weight, to adopt a healthy lifestyle, and at the same time you have to start some treatment so that, you know, if the not so aggressive treatments work, there is some results. We all know, we have all seen some obese patients also get pregnant. So I guess you have to find a balance on both sides. You have to keep in mind the age of the patient and various other factors. and the number of years that they have been married, etc. So
Yes.
on this square, I would like to ask Dr. Balen, where does he see the role of metformin, not only in just managing anovulation, but across the spectrum of PCOS in the adolescents? Does he see the role in losing weight, helping them to lose weight, or what would be his opinion? Dr. Balen, is he there?
I think that was a recorded talk. So
okay.
We could actually move on to the next topic with Dr. Effia Yasmin, our next speaker. She is a subspecialist in reproductive medicine and surgery and clinical lead in reproductive medicine unit, a senior lecturer at University College London. And Dr. Yasmin will be speaking to us on diagnosis and management of WHO type 1, 2 and 3 anovulation. So over to Dr. Yasmin and her wonderful talk.
Hello, greetings from London. I am Hello, greetings from London. I am Effia Yasmin from the University College London Hospital, and I'm extremely grateful to the conveners of this meeting for giving me this opportunity. Hope you have a great workshop. So I'm going to be talking about WHO type 1, type 2 and type 3 infertility. Not a very complex subject, and hope I have some insight to give you from current evidence and practice. Hello. The remit of my talk will be the definition of the three conditions, how we recognize and distinguish them from one another, and the management of the three conditions, including the management of subfertility, and hopefully a more holistic view of the three conditions. Let's take a moment to refresh our memory about the hypothalamo-pituitary-ovarian axis. So right at the hypothalamus, we have a neuronal network. It consists of those glial cells that will secrete the peptide GnRH. GnRH, or gonadotropin hormone releasing hormone, will stimulate the anterior pituitary to secrete the follicle stimulating and luteinizing hormone, which will in turn act on the ovary to cause folliculogenesis, follicular maturation, and ovulation. Now, this neuronal network doesn't act alone. It has the intermediaries such as the kisspeptin and the neurokinin B cells, and a network that has an excitatory role. The hypothalamus and these GnRH producing cells are also under the influence of leptin. Now, leptin is secreted by the white adipose tissue, and therefore any significant increase in weight or significant reduction in weight and a very low subcutaneous fat would have an effect on GnRH and cause disruption. The WHO definition of type 1 refers to women with primary or secondary amenorrhea with very low levels of endogenous gonadotropins, which is FSH and LH, and negligible estrogen activity, so very low concentrations of estrogen. Type 2 refers to women who have normal gonadotropins and normal circulating levels of estrogen, and PCOS falls in this group. And type 3 refers to women with primary or secondary amenorrhea with elevated gonadotropins and low estrogen concentration. Let's first look at WHO type 1, because there is a lot of information on the type 2s or on PCOS, and it's very well recognized, the definition is well established, but perhaps the WHO type 1 not quite so much. There are 3 subtypes recognized within the umbrella term of WHO type 1 anovulation. The first one is hypogonadotropic hypogonadism, and it includes various, again, conditions, and they can be congenital, such as Kallmann syndrome, infiltrative conditions that will act on the glial cells and therefore GnRH pulsations, and also acquired ones such as any brain surgery, chemotherapy, or radiotherapy. The next is hypothalamic amenorrhea. Hypothalamic amenorrhea is often characterized by secondary rather than primary amenorrhea and is associated with a chronic calorific deficiency. So we may see this in anorexia, bulimia, orthorexia. Now, orthorexia is the obsession with very healthy eating, and in the process, a lot of nutrients may be cut out from the diet, or say a lot of carbohydrates. And this may not be as easily recognized because they are not striking like anorexia. Then it could be excessive exercise and critical illnesses and chronic illnesses that will also interrupt GnRH pulse. Next comes hypopituitarism. Now, unlike hypogonadotropic hypogonadism and hypothalamic amenorrhea, where you may be diagnosing it for the first time when they attend your infertility clinic, in case of hypopituitarism, a diagnosis will often have already been made because it is associated with other comorbidities such as a low thyroid stimulating hormone and hypothyroidism, ACTH problems, and growth hormone deficiencies. So people may have already been diagnosed and would have maybe been treated. But if not, here again, the history you would obtain when you come across sort of amenorrhea and to exclude any pituitary causes would be looking at any kind of issues such as past history of meningitis, encephalitis, or again infiltrations and infiltrating conditions such as histiocytosis, hemochromatosis, surgeries near the pituitary for pituitary tumors, chemotherapy, radiotherapy, and sort of other syndromes that are associated with pituitary hormone abnormalities. So how would type 1 anovulation present to you, apart from, of course, oligo or amenorrhea? Patient may present quite early, even before attending your clinic for infertility. So one presentation may be delayed or arrested puberty. So the menarche may not be on time, breast development may be slow, or some development may have started and arrested, and that would be due to hypoestrogenism. And then, of course, the telltale symptoms of oligomenorrhea, amenorrhea, and understandably, conception delay. So how would we make our diagnosis? It's actually fairly simple, and we do not have to go down a very, very difficult route. First thing is obviously the history. So we start with age of any pubertal development, such as if there has been appearance of pubic and axillary hair, and what time that took place, and what time breast development or thelachy was noticed, and if there was any period at all which had subsequently stopped. We take the history of their eating habits, any weight loss, weight gain, and any history of chronic illnesses as described before. Then we would do some hormones, which we will come to in a minute, and we may use either the ultrasound or MRIs as indicated by history and the endocrine profile. We note the BMI, and then we proceed with the assessment of the different hormones. So the anterior pituitary hormones, the sex steroids, prolactin, and AMH. Now, testosterone and AMH are not absolutely essential for the diagnosis, but they do help us differentiate between the conditions when sometimes the picture is a little bit confusing. Next comes a pelvic ultrasound scan. You would want to know actually that there is a uterus with functional endometrium present, and then you look at the ovaries. So you look for either very quiescent ovaries or polycystic ovaries, and you would also want to measure the volume of the ovaries. So when you look at the uterus, if there has been chronic hypoestrogenism, you may see a very infantile uterus or a small uterus with a very thin endometrium. As you know, the endometrium is a marker for estradiol. So a thin endometrium would signify low estrogen, whereas a very thickened endometrium could signify unopposed estrogen, such as in PCOS. If your diagnosis is not that of clear-cut PCOS or premature ovarian insufficiency or hypothalamic amenorrhea, you may want to do some brain imaging to rule out any, again, infiltrative conditions or pituitary problems. If you have identified hypoestrogenism, it would be very prudent to carry out a DEXA scan to measure bone mineral density and identify any osteopenia or osteoporosis, so you have an opportunity to correct that before they embark on their fertility journey. So this simple table is often enough to give you the diagnosis or differentiate between the conditions. So with FSH, LH, estradiol, so if it's normal or if LH is high, your diagnosis is most likely PCOS. If your FSH and LH are low, you've got WHO type 1. Now, just a word of caution here. Hypothalamic amenorrhea may not always reveal a low FSH, and there the telltale sign would be a low LH. So you may have a low LH in the presence of normal FSH. The estradiol for all three WHO type 1 conditions will be low. So low gonadotropins, low estrogen. Whereas in premature ovarian insufficiency, you will note high FSH and LH with low estradiol. AMH, well, sometimes you may find that you have polycystic looking ovaries in both WHO type 1 and type 2, and there the AMH can often help you differentiate, because if you have high AMH, it's more likely to be PCOS, whereas if you have low or normal AMH, it's more likely to be WHO type 1. You often get a false low level of AMH in WHO type 1 because the ovaries are suppressed. They are like ovaries which have had GnRH agonist suppression. Testosterone is also helpful in differentiating. So if you have a normal to high testosterone, it's more likely to be PCOS, whereas if the testosterone is low, it's more likely to be WHO type 1. Weight is interesting. So you may get all types of weight in PCOS, and we know about the association of high BMI with PCOS, but you will observe that in the hypog group as well, whereas in the hypothalamic group you will often see a low BMI. Now the uterus, you may see a small uterus in hypog and hypopituitarism, and sometimes in hypothalamic amenorrhea as well. Endometrium will often be thin in WHO type 1, whereas it might be thick or normal in PCOS. And as you're aware, women with PCOS are also at risk of endometrial hyperplasia. Sometimes it might be difficult to distinguish between lean PCOS and hypothalamic amenorrhea, and there the LH and testosterone are really helpful, because if you have increased LH with normal or increased testosterone, you have a diagnosis of PCOS, whereas if you have a very low LH with a very low testosterone, your diagnosis is hypothalamic amenorrhea. Management will depend on the diagnosis. So once you've made your diagnosis, what I would say is optimization of BMI. So if you have low BMI, then with lifestyle changes, dietary changes, and maybe alteration of habits such as the exercise habits, you would get optimization. Also suffice to say that you might need a multidisciplinary help to achieve this, which I'll come to in the next slide. And if you have higher BMI, again, we would have to advise patient to lose weight, because we know that an adverse pregnancy outcome is associated with extremes of BMI. We have to address the cause and do all we can to address all the other issues associated with the condition. So for example, if you have impaired glucose tolerance, or if you've got diabetes with PCOS, we've got to address that and make sure it's optimized. And if we have, let's say, a patient who has WHO type 1 with low bone mineral density, then we have to make sure we've addressed that with adequate estrogenization and calcium, so that they don't start pregnancy in poor health. If they are hypoestrogenized, such as in WHO type 1 and in premature ovarian insufficiency, and they are not on HRT, then we would recommend that they get started on HRT, provided they do not have any other contraindications, so that the body has had time to be estrogenized, as well as the uterus and endometrium have the chance to be primed. And then we proceed to ovulation induction in type 1 and type 2. So we shouldn't think that the weight of management should fall only down to the gynecologist. We will need the help of the dietitians, the nutritionist, the psychologist, because we know that any eating disorders, be it binging or anorexia, bulimia, orthorexia, are all linked to mental health. So the help of the psychologist would be extremely beneficial. And again, in any hypopituitarism, you will need the help of the endocrinologist to make sure, say for example, their growth hormone is optimized. So we need to adopt a multi-professional, multidisciplinary approach. Few important points. If your patient has been on the pill for irregular periods and actually has WHO type 1, so she may have had withdrawal bleeds, But at the same time, if the background situation has been that of hypoestrogenism, there may have been, kind of bone loss or inadequate estrogen supplementation, and there may have also been sort of a continued energy deficit that may have been masked by the fact that she was having periods. With addressing bone health, we know that bisphosphonates are used in menopause. However, in women who are seeking to conceive, this is not a good choice as it is associated with miscarriage and small for gestational age babies. So bisphosphonates should not be used in this population. So should you be giving any estrogen prior to ovulation induction? So some of your patients may be on HRT already, but use of HRT is not very popular or not really well established in WHO type 1, and often they are not diagnosed early on because they do not have raised FSH and LH, so nobody thinks that they are in failure, so they are not given estrogen. And often estrogen is not measured in the first place. So if they have been chronically hypoestrogenized, it would be a good idea to give them some estrogen pre-treatment before actually proceeding to ovulation induction. So as I was explaining with the imaging section, women who have hypogonadotropic hypogonadism or hypopituitarism tend to have smaller uteruses than normogonadotropic women. So this is something to be borne in mind, and especially as it may have an impact on their reproductive outcome. So let's talk about ovulation induction. So the aim of ovulation induction is to try and mimic the natural cycle as closely as possible to get one single ovum released. So we have to be careful against multiple ovulations, which increases the risk of multiple pregnancy, twins, triplets, which is obviously a risk. So I'm going to talk about ovulation induction in WHO type 1 first. So clomiphene or even letrozole are very common ovulation-inducing agents we are very familiar with. But should we be using clomiphene when it's WHO type 1? Well, not really, because clomiphene is an anti-estrogen, and women with WHO type 1 and ovulation already have a background of low estrogen. So why would you give something that is essentially an anti-estrogen? Plus, we know that LH is an essential requirement of follicular development and oocyte maturation. So women with WHO type 1, we've already established, are LH deficient. So you need something with additional LH, and therefore clomiphene wouldn't be a suitable agent. So the appropriate ovulation-inducing agent for WHO type 1 will be either human menopausal gonadotropins, so it has LH activity as well, or recombinant FSH but with additional recombinant LH. Now we cannot use recombinant FSH alone because once again they are LH deficient, they need LH. So ovulation induction is a fairly simple process with HMG. So the first method is to go low and slow and increase as you progress through the cycle. You monitor the response. So you try to find that FSH window at which follicular recruitment and dominance takes place. So you keep going and you do not worry about WHO type 1 patients not ovulating on day 14, day 15, etc. and taking longer, because the start of the cycle is essentially when they start recruiting. So you keep increasing, say every 7 to 10 days until you get your recruitment. So you trigger with HCG and The trigger time is the same. A follicle of more than 17, at least, it can be 18, 19, 20, 21, doesn't really matter. And then you add LH. Yes, any corpus luteum will give endogenous progesterone, but these patients who have already had low sex steroids may need some additional luteal support, especially because there's an association of WHO type 1, especially hypopituitarism, with increased risk of miscarriage. The other method is a step-down protocol where you start on a slightly higher dose and you step down as soon as recruitment takes place. Now, this process is not uncommon and quite suited for PCOS, but not really for WHO type 1, because you may get an over-exuberant response right at the beginning because you don't know their FSH window. And once they recruit lots of follicles, it might be difficult to control and you may run the risk of an over-response. The GnRH pump was a very useful ovulation-inducing device for WHO type 1. So because the issue is that of a lack of the pulsatile release of GnRH, and the pump would deliver that, but sadly it's no longer available. What about growth hormone? We know growth hormone can assist with follicular development, and for patients with hypopituitarism, they may have growth hormone deficiency, and so this group is likely to benefit from either the continuation or addition of growth hormone, but there is limited evidence in the benefit of growth hormone in other conditions. So luteal phase support can be offered in two ways. One is the addition of progesterone, such as vaginal micronized progesterone, or with the addition of HCG. So HCG being continued beyond achieving the trigger. So for example, in the subsequent 2 weeks up to ovulation, there may be additional, say, an HCG every 3 to 4 days. Whilst we have loads and loads of data on ovulation induction in PCOS, data on WHO type 1 is actually pretty small. So this is a study from Prof. Balin, and several years old now, but kind of illustrates how you might expect WHO type 1 to respond. So in comparing the three groups, HyPOG, and PCOS seem to respond very similarly, with a pregnancy rate of about 20 to 22% per ovulation. That is in keeping with what you see in natural conceptions. And the outcome seems to be pretty good with weight-related amenorrhea or hypothalamic amenorrhea. Miscarriage rates, you can see, are slightly higher with hypogonadotropic hypogonadism. And let's not forget the uterus and the endometrium. I have already emphasized that women with WHO type 1 and ovulation, especially if hypoestrogenized from very early on, will have a small uterus with thin endometrium. So endometrial thickness is clearly associated with pregnancy outcomes. So the thinner the endometrium, the lower the outcome. And indeed, we see this in our population, that as the thickness increases, we get better pregnancy rates. And this is not difficult to perhaps appreciate, because endometrium reflects the circulating levels of estradiol. So again, unlike PCOS, you will not find much information or guidance on ovulation induction in this group, and this is guidance I led for the British Fertility Society, which I would welcome you to look at. PCOS, on the other hand, has had a lot of scrutiny, and the international evidence-based guideline was published, and which was actually reviewed and endorsed by lots of fertility societies across the world, and you will probably be very familiar with the contents of this guideline. So before I move on to the contents of the guideline, I would again like to highlight that the success often depends on little details such as optimizing the BMI as best as you can, and addressing any endometrial issues, because we know that women with PCOS are at risk of endometrial hyperplasia, and if that is not treated, so if we do not give due attention, we may be compromising the outcome of the cycle, and indeed, failing to diagnose precancerous conditions. So this is not to cause a lot of worry in the patients, but I think any thickened endometrium that you see in PCOS patients needs to be evaluated. So we know that women with PCOS, especially with high BMI and increased insulin resistance, are at risk of diabetes, and this also needs to be assessed and addressed prior to starting treatment. So what does the guidelines say? Well, India has been a pioneer actually in the use of letrozole, and yes, this was started quite early on while the West was still catching up. But yes, the good news is that letrozole is now regarded as the first-line pharmacological treatment for ovulation induction in women with PCOS. You get more monofollicular ovulation, you get less of the anti-estrogen effects, and it does not seem to increase the risk of congenital abnormality. And of course, good old clomiphene citrate still has a place. The doses, well, can be anything from 25 to 150. The usual start dose is 50, and you increase or decrease based on response. Again, it's extremely important to monitor at least 1 or 2 cycles to check that the endometrial development has also been optimal. Gonadotropins still remain a second-line treatment, and here, unlike in WHO type 1, we can use FSH alone, as we have no issues with LH in PCOS. Well, I say no issues, but some women will have a very elevated level of background LH, and actually that is also associated with poorer outcome and increased risk of miscarriage. So any high LH at baseline you might want to address. So for example, with the use of ovarian suppression with either some progestogens or with the combined pill beforehand. Laparoscopic ovarian drilling, again, nothing new. And perhaps in the presence of so many other non-invasive options, this is not often used, but it still has its little place in the management of PCOS. But what I would say is that we absolutely should be measuring AMH prior to doing any drilling, and you don't want to therefore reduce ovarian reserve in somebody who may already have a diminished ovarian reserve but is being characterized as PCOS. There would be a risk of adhesions, but if we are struggling with ovulation induction, and especially in women who are consistently getting over response, there is a benefit of drilling. And you know that the studies show that women of normal BMI or who are lean with elevated LH may benefit from laparoscopic ovarian diathermy. So again, cannot be emphasized enough but there may be an associated risk of diminished ovarian reserve or loss of ovarian function, especially if the use of diathermy is enthusiastic. So WHO type 3 is sadly premature ovarian insufficiency. So, although this is an ovulation, it's an ovulation because there are no eggs for ovulation to take place. So clearly, ovulation induction is not an option in this group. How do we diagnose premature ovarian insufficiency? I point to the ESHRE guidance that defines premature ovarian insufficiency. Again, it's only applied to women who are less than 40. So that means any menopause, say after the age of 40, isn't quite classed as premature ovarian insufficiency. And how will we diagnose? Well, this is a good practice guidance rather than from any specific research, but it is characterized by oligo or amenorrhea for at least 4 months and an elevated FSH of more than 25 on at least 2 occasions 4 weeks apart. So one of the options for pregnancy for women with premature ovarian insufficiency is egg donation. And before embarking on any egg donation, we again have to pay attention to optimization of their health. So women with premature ovarian insufficiency or POI may have diminished bone mineral density, osteopenia and osteoporosis. Women with Turner's may have the risk of aortic dissection, so they have to have an echo before they start any treatment. We need to have a look and see what their endometrium is like and if they have been on HRT or without HRT. And also do a simple cardiovascular check, especially with say, blood pressure and any ECG where required. The focus of my management plan has been on ovulation induction, but we know that IVF is extremely popular and some women with ovulation may not respond to ovulation induction and go on to having IVF treatment. So in PCOS, there will be an increased risk of ovarian hyperstimulation syndrome. So the antagonist cycle with the benefit of agonist or dual triggers is currently the norm. Women with type 1 anovulation may also respond similar to PCOS. That means they may also over-respond. But we have to be careful because we cannot actually use agonist triggers in this group. And also because they already have low LH and they cannot have ovulation on their own, we do not need to use cetrotide. So they do carry a risk of OHSS, but we will only have the option of trigger with HCG. So we have to be extremely cautious with regards to their risk of OHSS. Well, the whole purpose of all our management plans is to get a healthy mom and healthy baby at the end of the day. So what evidence do we have for outcomes of children born after ovulation induction? Well, actually, contrary to, say, IVF population, children born from ovulation induction is actually not under so much scrutiny. So I have this Finnish study that had a sizable population, and very importantly, what they did find was even when you discounted multiple pregnancy, the outcome for children with ovulation induction seemed to be poorer than those conceived naturally. I suppose one reason for this would be there are some background conditions associated with the different types of anovulation. We have already looked at the various comorbidities that can exist with WHO type 1, we have issues around BMI as well. And again, in PCOS, they may be at risk of diabetes. So perhaps it's not difficult to understand why this might be the case. And that's why I've emphasized optimization of health so much. So the perinatal risks identified are preterm birth, low birth weight, and increased admission to special care. So just to summarize and present some take-home messages, the first thing I would like to say is to optimize BMI and aim to commence ovulation induction in the best possible health. So address all the issues and the comorbidities that may be associated with the different conditions. When doing ovulation induction, aim for monofollicular ovulation. Well, we shouldn't be in haste to go to IVF, and we should try 6 to 12 cycles depending on other situations and other factors such as age. And if IVF is carried out in type 1 and type 2, OHSS is a risk, and the treatment in premature ovarian insufficiency is egg donation and not ovulation induction. Thank you. So that brings me to the end of my talk. I'm so sorry to not be able to be with you in person, even if it's virtually, because I am operating now as you're listening to this talk. I would welcome any thoughts or questions, or even any suggestions, and if they can be presented to one of the course organizers, I would be very happy to respond. Thank you very much.
Fantastic talk, and I think it was all encompassing. So I would like to invite Dr. Asha Bakshi. I think she has a few interesting comments and questions to ask Dr. Yasmin. Dr. Bakshi, over to you.
Thank you very much, Dr. Yasmin, for such a nice presentation. Presentation very simplified and with very good take-home messages. Few questions I had. One is that these patients who are on HRT, they conceive, and once they deliver, then many people forget to give HRT to these patients. So I think that is one field one has to sensitize. And when should the HRT be started? How many months after the delivery? Because she's lactating, and you're always wondering when should we start. So would she be able to answer this question, Sabina?
Well, she's on the group, and
I think I spoke. I saw that thing on the screen on the mobile, and she did say that once you stop lactation, then you can start HRT. So,
correct. Yeah,
I think so. Asha, she did say that there. Sabrina, on a group, see whether you have any more questions.
Yeah, there is one question by, I think, Dr. Sujata Garg, and that is, what treatment would you prefer in hypo in unmarried? So I think in hypo in unmarried, one has to really, you're not planning for pregnancy, so you have to give HRT to these patients. And another question is again by Mangla Athavle from Indore. How do you deal with small uterus and thin endometrium? So again, I think here you have to give HRT and
Aisha, where in an adolescent with the hypo, even if the patient's aim is just to have a regular menses, by putting on these HRT, we help them to develop the uterus. So when they get married, when they have to go for a pregnancy, the uterus is already, otherwise we have to waste like 9 months, 1 year just to develop the uterus. So there are many false advantages. Apart from the effect of estrogens, the help for the bones and the heart and everything, very important is the uterus also get developed simultaneously for future pregnancy.
Yeah. One more thing is these young girls who especially have primary amenorrhea, they may find it, the secondary sexual characters may not be so well developed. So if you give HRT, it will help in that also. And especially in the beginning, you have to give continuous estradiol for some time so that the breast development is good, secondary sexual characters are good, and then after some time you start with progestogen.
Yes, Dr. Latika Chawla, is there something that you would like to say at the end of this session? Over to our chairpersons.
I actually had a question if Dr. Tandulwadkar would be able to answer. Madam, in your experience, what is the best way HRT to these young girls? As you mentioned that it helps in the development of the uterus.
But I don't give a high estrogen, dear. I don't give a high estrogen oral contraceptives because I work in an institution and I have handled many cases of our physicians of thromboembolism in these young adolescents. They were given only for a regularization of the menses at 14 and all. I don't know why even we want to regularize the menses at the age of 14. And I had faced a lot of these patients which came to the tertiary hospital in a ICU because of the cerebrovascular accidents and thromboembolism. So I'm very, very careful about giving high estrogens. One. Second important thing is I always ensure that these girls, they drink lots of water because, you know, usually if you experience in a school going or a college going girls, lack of good toilets or whatever it is, their hydration is never, we become more cautious about the hydration after 30s, I feel. In a college or a school girls, we don't see so much of importance. So these are the parallel advices. I would always ensure that when I give these young girls the HRT treatment. Combination pill, taking one pill is most important for them than having any variants because it becomes more practical and easy. Do you think those adolescent girls have a habit of popping up the tablets every time? No. So low dose OC pill is good enough for them. Keep on doing their bone density scan. All this is important. By giving a very high estrogen, you may cause early closure and short growth also. So you have to manage. I love to have a pediatric endocrinologist with me who can keep on doing those parallel activities and you just concentrate on other part. But very important at adolescent age group to counsel the family about her further married life and when she will be getting married, explaining to the in-laws or whatever the husband is, because she don't want to face the problems after marriage. All these things, especially in India, matters a lot.
Right. Thank you very much. I think we've had a very interesting session here. Fantastic talks by Dr. Belan and Dr. Yasmin. Moving on now, I came across a very interesting quote that said that, look at the stars, see their beauty, and in their beauty, see yourself. I want to paraphrase it as, look at the stars, listen to them on this session, and in their wise words, improve your practice. Moving on to our next session, may I invite our chairpersons, Dr. Sarita Bhalerao. Dr. Sarita is Vice President, MOGS 2020-21. She is our chairperson of AICC RCOG West Zone. And Dr. Asha Bakshi, who is Director and Chief of Obstetrics and Gynecology at Dr. Asha Bakshi Fertility Center. She is Vice President-elect FOXY for West Zone. Madam, welcome to this session.
Dr. Hema will also agree that...
Thank you, Dr. Sabrina. Thank you for that kind introduction.
So our first speaker for this session is Dr. Rishikesh Pai. Dr. Pai will be speaking on PGTA to improve pregnancy outcomes. Welcome, Dr. Pai.
Hi. Hi, Sabrina.
Hi. Hi.
Hi. Should I start the screen? Can I start the screen?
Yes, sir. Yes, sir. Please, sir.
Yes, please.
One second. I would like to first and foremost thank Dr. Sunita, who is the president of the POGS and the AICC RCOG and the Pune Obstetric Gynec Society, as well as Dr. Sarita and Dr. Asha and all the other people for inviting me for this talk. I'll just be very short. Pre-implantation genetic testing has been redefined as PGT now, and it can be for monogenic disorders, which is known as PGT-M, or it can be for aneuploidy screening, which is known as PGT-A. And if for the monogenic disorders, normally indications are for patients with structural chromosomal anomalies in the parents, single gene disorders like beta thal, sickle cell anemia, which are common in India, and cystic fibrosis, which is common abroad, mitochondrial disorders. We can use it to deselect genes predisposing to hereditary cancers like BRCA1 and 2. You can select a histocompatibility sampling in patients suffering from thalassemia or in young patients suffering from cancers. Then you can use it for expanded carrier screening. And then, of course, the new thing is to use them for polygenic disorders like diabetes, which is still in the experimental phase. You can use it for aneuploidy screening as well, which is called PGT-A, and that is normally done for patients with advanced maternal age, more than 35, with recurrent implantation failures or repeated IVF failures, recurrent miscarriages. And mainly it is used to reduce the time taken to pregnancy, reduce the miscarriage rates and multiple births, because we try to select a single embryo for transfer. So that obviously the multiple births can be reduced. And now a lot of newer techniques are now in the horizon, such as IVM, freezing, spindle transfer, CRISPR. So, these embryos which are formed from this, we need to also analyze these embryos to look for genetic disorders. So if you look at the biopsy techniques, there are two standardized techniques. One is the blastomere biopsy, first introduced by Dr. Alan Handyside, and when he had selected in 1989 the birth for thalassemia, PGD for thalassemia, and then of course the standard trophectoderm biopsy, where you biopsy the trophectoderm which forms the placenta, thus preventing damage to the inner cell mass from which the baby is formed. So one of the important things that has happened is that there's a lot of breakthrough in terms of blastocyst culture techniques and vitrification, and due to the ideal culture technique, especially 590 mixtures, benchtop incubators, the blastocyst formation rate has increased, and this in combination with a safe laser hatching with trophectoderm biopsy and a good vitrification has resulted in a lot of these patients being subjected to the technique of PGT-A. So if you look at the technique, it is easy to perform. It is minimally invasive because of laser hatching. Less skill is involved compared to blastomere biopsy. Ease of vitrification enables proper genetic testing using NGS. And you can do a frozen embryo transfer and transfer the embryo only when there is an ideal receptivity. And this, along with the added advantage of blastocyst transfer in a frozen thaw cycle, gives it a very high pregnancy rate, decreases the multiple pregnancy rates, decreases miscarriage rates, and increases the chance of a genetically normal birth. So initially, when we started offering PGT-A, we used to use the fish technique, but it only covered 12 chromosomes, and then we moved on to the CGH microarray technique, which is a very good technique. It is very quick, it is cheap, easy, fast, has low failure rate. However, there are problems, especially with mosaic embryos, and then came the technique of the NGS, which is as you can see here in this video, you can take the trophectoderm biopsy, use the laser to cut. So we take about 4 to 6 cells. Once these cells are taken, you can even take the culture media around the embryo. It's very important to collect this tissue very properly. Otherwise, you may contaminate. And contamination can be embryo DNA contamination from the embryologist, from the mother as well, maternal contamination. So you have to be very careful. Once you do it, you have to tube it. So you have to put it in a buffer. And once you put it in a buffer, you freeze it. Normally, we freeze these tubes at minus 20 degrees centigrade, and you need to accumulate the tube because you need at least around 10-20 embryos. Like normally when we run our batch, we need 30 embryos. So we need to freeze them, and we counsel the patient that it will take about 2 to 3 months before you get the report. Of course, there is a number of embryos. Now our labs have started doing more and more patients. So as the number of embryos load goes up in the lab, you are naturally going to have lesser time for analysis. But at present, we counsel them for between 2 to 3 months after we take the biopsy or we take the spent culture media. And then this is, once there are enough embryos, we thaw them and then we vortex them because the DNA is settled at the bottom of the tube. So we vortex them and we display the DNA. And once vortexing is done, then we amplify the DNA we add nucleotides and we amplify the DNA in a PCR machine, which is done for a 1 hour amplification cycle. After the 1 hour, we take it out and then add the library. So what is the library? There is a code. There is a barcode. Each of the embryos is separately barcoded with a specific code. So because we are going to mix all the embryos together in one tube, we need to see that there is a barcoding. So this is the PCR machine where amplification takes place, library addition and subsequent second amplification. So total amplification time is 3 hours. After the amplification is done, then we take it and we create in the template formation. So in the template generation, we mix the samples and that fragmented DNA is stretched over magnetic beads. They are called magnetic microbead amplification. And then all these are mixed into a simple single cartridge. So that takes about 3.5 hours. So you can see this is the template generation where all the DNA is mixed into a single cartridge. It is automatically done and it takes about 3.5 hours. And after that is done, the cartridge is taken out and it's put in the sequencer where the sequencing is done in parallel. So there is a massive parallel sequencing that is done. That takes about 4.5-5 hours. So normally we run the sequencer in the night. And in the morning, we upload the data onto the cloud where the classification is done and the reading is done either by the PhD or he can use artificial intelligence and also read it. So this is how we do it. So once the cartridge is formed, this is the cartridge and this cartridge is then put in the sequencer. So this is the sequencer and then, you read the machine. So you can see here, you do the whole genome amplification, then you do the isotomer amplification, then you do the sequencing and do the data analysis. And this is how we read the embryo. So this is a euploid embryo. So this is a two chromosomes. So this is a 0. So you can see that is a normal embryo. But if you look at this aneuploid embryo, minus 18, one chromosome at 18 is not there. So it goes to the level of this marker goes down and that is a minus 18 aneuploid. So the advantage is that the NGS is more accurate in detecting partial aneuploidies, mosaicisms and translocations compared to the CGH microarray. Of course, it is time consuming, costly, but it can do around 90 embryos at one time. And as the number of embryos increase, the cost of the test will go down. And if you compare, this is a study by Friedenthal in 2018 where he has shown that in mosaic embryos, the NGS has a better outcome than a microarray technique. So what are the disadvantages of trophectoderm biopsy? It is costly, needs skilled manpower, it's invasive comparatively, and we don't know what are the long-term damages to the embryo, and there may be problems of mosaicism. So what is mosaicism? So in this embryo, for example, this is a trophectoderm which is normal, but the inner cell mass from which the baby is born is abnormal. So if you take a biopsy from here, the diagnosis will come as normal, but actually it is an abnormal embryo. And if you transfer this supposedly normal embryo into the uterus, then either there will be no implantation or there may be a miscarriage, and sometimes worse, sometimes the abnormal fetus may be born if you are not careful and you don't do a proper antenatal screening. On the other hand, in this embryo there is an abnormal trophectoderm but a normal inner cell mass. So if you take a biopsy, this is called false positive, and many of these embryos may get discarded by mistake. So it may be a normal embryo, but you may think that it is abnormal. So the mosaicism, unfortunately for us, the incidence of mosaicism is around 5 to 6%, and there is a standard protocol which is followed by each lab for selecting mosaic embryos. Does this PGTA really make an impact? And Santiago Mune did a trial in fertility study in 2019 where he had 661 women and he had two arms of 330 and 331 each. And he randomized them. And one arm was subjected to PGTA and one arm was subjected only to morphological assessment of the blastocyst before transfer. And they found that in women less than 35, there was no difference in outcome, either in the pregnancy rate or in the miscarriage rate. But in women above 35, there's a 14% increase in the pregnancy rate in the arm where the PGTA was used for analysis. But the seminal study in this has come from Purty et al. In January of 2021, where he showed that the live birth rates after the first, second, and third frozen set transfer, single embryo transfer of euploid blastocysts resulted in 64%, 54%, and 54% pregnancy rate, live birth rate per transfer, and a cumulative live birth rate of nearly 92.6%. And the conclusion was that the findings suggest that true recurrent implantation failure is very rare. It's a fabulous study which has come from Purty, and there is this the observation in RBM Online saying that the STAR trial showed that rather than a lack of improvement in live birth rate, the indiscriminate use of PGTA implies a loss of potentially competent embryos due to the wrong diagnosis and or biopsy-related embryo damage. So biopsy-related damage is a big problem, and hence this new technology of non-invasive screening that came in was initially introduced by Zhu et al. In 2016, which I went to train in their lab in Shanghai in 2019. I brought back to India, and this is based on the Malbec technology, which we use in amplifying the spent culture, the DNA which leaks out in the spent culture media, and we amplified. And if you look at the concordant studies, the latest studies of Rubio et al. Have shown nearly 84% concordance between the biopsy results and the results of the spent culture media. Even our studies are showing very good results nowadays. And the advantage of non-invasive technique is that embryos remain intact. There is less strict requirements on equipment, training, techniques, much easier to handle, simple, can detect PG level genetic material compatible with both the platforms Illumina and Torrent, and implantation potential is assessed rather than the aneuploidy status of the embryo. And this was a study by Rakowski in 2021, and she has said that non-invasive PGTA will prevail over invasive PGTA because of the main reason is available evidence has indicated the performance superiority of non-invasive PGTA over that of invasive PGTA, and therefore greater reliability of NIPGTA for the determination of embryo karyotype. And the practical limitations of NIPGTA include the fact that NIPGTA effectively addresses the potential for sample loss. See, because there can be damage to the embryo, sometimes the sample loss may be there. So what are our observations? Over the last 1.5 years, we have done a lot of work now. So one has to have robust counseling. Non-invasive, we have to tell patient that it is non-invasive, it grades the embryos, and we are not going to discard any embryo. Proper dissection of cumulus cells is important to prevent maternal contamination. Nowadays, we do day 5, day 6. So when the blastocyst is actually expanding, that is the time we collect and we get the best DNA. If blastocyst does not expand on day 5, we give a laser cut and do assisted hatching. If still the blastocyst does not expand, we do a traditional biopsy, or we tell her that we have not subjected the blastocyst to a NIPGTA. So we culture blastocyst in 20 microliters of, specially every media is different. So we use the Queen's media. And normally we freeze the blastocyst. Even if it is a day 6 blastocyst, we will transfer the blastocyst on day 5. And sometimes if there is a DNA amplification failure, we can compensate the patient by counseling her that will thaw the embryo and do a traditional biopsy, refreeze the embryo and do the analysis at no extra cost. So we have done a lot of patients now. We are very happy with the results. A lot of other doctors have started sending their patients to us. And you can see that if you have a single euploid blastocyst, then you can, even irrespective of the age of the patient, you can transfer only a singleton pregnancy and get very good results. So in summary, I would like to say blastocyst culture may be the preferred way forward for all cases. Single embryo transfer using non-invasive testing may be done, resulting in decrease in the time taken to pregnancy, decrease in the multiple pregnancy rates, and increase in the implantation rate. This can be offered to the first time or second time embryo transfer patient. NIPGTA may be done keeping in mind that we are more focusing on the implantability of the embryo rather than on its genetic status. Grading and selecting best quality embryos using the invasive method of trophectoderm biopsy with PGTA is ideal in patients more than 35 years of age, or more than 2 RIF, or more than 2 miscarriages, or with an abnormal embryo in the past. As we evolve, even this can be replaced. We are slowly becoming more and more confident, and we'll be able to ultimately replace even the invasive PGTA with non-invasive. Remember that most of us had a successful IVF practice without doing PGT, as we all consider this just as an add-on. It is better to have a non-invasive safe technique rather than better to have a non-invasive safe technique with a concordance of 80%. PGTM should be done by traditional methods of PGTA with T biopsy and genetic. However, recently non-invasive PGTM is being effectively carried out using linkage. So we were restricting it PGTA to non-invasive, but PGTM also. Recently, my Chinese collaborators have told me that we can even do the PGTM, single gene defect, using a non-invasive method, using linkage analysis, and we are looking at this technology for the future. The future will be combination of time-lapse, artificial intelligence, non-invasive chromosomal screening or NIPGTA, and NGS for implantation window with a single embryo transfer, minimizing miscarriages, maximizing the chance of a genetically normal infant without any imprinting disorders. And I would like to end my talk by showing you these two darling women. I'm their fan. This is Emmanuel Charpentier and Jennifer Doudna, who got the Nobel Prize for CRISPR. It was the shortest Nobel Prize. They discovered CRISPR in 2014, and within 6 years, they were given the Nobel Prize in 2020. Thank you for a patient hearing.
Thank you very much, Rishikesh. That was a very crisp presentation as usual. Thank you very much. And I would like to welcome our chairperson, Dr. Latika Chawla, who is a member of AICC RCOG.
Sabrina, it's Dr. Sudeshna Ray.
Oh, sorry, Dr. Sudeshna Ray. Okay, Rai, I guess. Yeah. She is a consultant at Jaslok, Saifi and Reliance Hospitals with a special interest in robotics and endoscopy. Welcome, Dr. Sudeshna. As we move on to our next speaker, Dr. Gautam Khastagir.
Can I just give one comment?
Yes, please.
That was a spectacular talk, and your passion was so well, and I definitely feel genetics, artificial intelligence, embryoscopy all together will help us to give more healthy baby. Wonderful here.
Thank you. Thanks.
Dr. Gautam Khastagir is our next speaker, and he will speak on recurrent implantation failure. Over to you, Dr. Gautam.
Good afternoon, ladies and gentlemen, respected chairperson and all delegates. It is indeed a great honor and pleasure for me to present my work on the topic of recurrent implantation failure to you on this conference organized by Pune Obstetrician Society. Now, recurrent implantation failure is often considered as a hurdle race. You know, in hurdle race, you have to cross different barriers, and recurrent implantation failure is often like that. Now, before understanding this problem, we need to know about implantation. Implantation is a cascade of paracrine and autocrine signals triggered by steroid hormones. There are many agents like growth factor, interleukins, cytokines. They play a very important role. And for this process, there needs to be some changes in both stromal as well as glandular component of the endometrium. And we all know pregnancy or baby is a foreign body to the mother, so there needs to be an immunotolerance to accept the embryo in the endometrium and uterus. So with this complex scenario of implantation, we need to have several factors in line to make it successful. Now, in some women, it doesn't happen, and repeatedly it doesn't happen. So what is the definition of recurrent implantation failure? Initially, we thought if 3 embryo transfers done with high quality embryo, 3 successful embryo transfers, 3 attempts, no success, that should be defined as RIF. But subsequently, ASHRAE has suggested more than 10 embryos in multiple transfer. Sometimes you transfer 1, sometimes you transfer 2, sometimes you transfer 3. So if you have transferred 10 good quality embryos and still not successful, that is RIF. Now, some recent papers have suggested that failure to conceive a clinical pregnancy after transfer of 4 good quality embryos in a minimum of 3 fresh or frozen cycle in a woman under the age of 40. Now, the numbers are coming down, 4 good quality embryo, because we are now transferring blastocyst. So we are transferring only 1 or 2 blastocysts. So in 3 fresh or frozen cycle in women under the age of 40, we need to get result. Another paper has similarly said failure to implant in 2 cycles after transfer of at least 2 good quality blastocysts or 4 good quality embryo. So the jury is still out. We do not have a uniform definition of recurrent implantation failure, but from this slide you can easily understand that we need to have good quality embryo, and after reasonable attempts, if we are not getting successful, then it is a big issue. Now, what are the risk factors of RIF? What is the maternal age? Older the mother, greater the risk of this problem. Body mass index, obese women have a much higher risk. Smoking, which is very common amongst women, particularly in the Western world, but also in our subcontinent. And finally, stress. We are all stressed out because of our work, because of our responsibility. We are stressed out, and that cortisol hormone has adverse effect on implantation. Let's look at the cause of RIF. We can divide them into 3 groups. We know for implantation, we need seed and soil. So we need very good quality of embryo, we need very good endometrium, and we also need a good gardener who is going to put the seed in the soil. So the causes are threefold: poor embryo quality, lower endometrial receptivity, and suboptimum embryo transfer. Now, if we take one at a time, if the embryo is of not good quality, it could be because of the chromosomal abnormality in the egg and sperm. It could be parental chromosomal abnormality, some chromosomal problem with the parents. If the zona pellucida is hard due to the age of the patient and due to the culture problem in the lab, and the embryo culture, if it is not optimum, they all lead to defective embryo development or abnormal embryo development. Now, coming to the endometrial receptivity, it may not be adequate or optimum because of several reasons, be it fibroid, polyp, intrauterine adhesion. It could be congenital abnormality like septate uterus, subseptate uterus. Sometimes the endometrium is not good enough because of tuberculosis, because of previous surgery. Asherman syndrome may be the problem. It could be adenomyosis, endometriosis, polycystic ovary, hydrosalpinges. These are all indirectly responsible for making the endometrium unsuitable for implantation. And even we know that controlled ovarian hyperstimulation, which causes hyperestrogenic state, makes asynchronization between the glandular and stromal part of the endometrium and actually prevents implantation or reduces the chance of implantation. In addition, there may be problems like immunological factors, thrombophilia, where there is microscopic clot formation, and there may be abnormal trophoblastic invasion. So therefore, many patients have recurrent implantation failure, like recurrent miscarriage, because of this microthrombi formation. There may be very local dysregulation in the endometrium, and this is at the molecular level dysregulation. Could be defective expression of the interleukin, changes in pinopod expression, failure of the appearance of specific integrins within the endometrium. Now, next is most important, where the clinician plays an important role, which is embryo transfer. If the clinician cannot perform it optimally because of his or her limitation or because of the circumstances, because of the anatomy, because of the position of the cervix and the uterus, that may result in failure of implantation. So this may lead to damage to the endometrium, damage to the cervix, which leads to contraction of the uterus and expulsion of the embryo. If the procedure takes longer than usual, if there is pain requiring change of catheter, need of uterine manipulation and cervical dilatation, these are all big no-nos. So that's why ideally we should have a dummy transfer or a trial transfer before the actual embryo implantation or embryo transfer, because we do not want to go through this difficulties with a healthy embryo in the catheter. So if we have a dummy run and if we can overcome all these difficulties, maybe a hysteroscopy before if there is problem at the cervix, problem with the dilatation, problem with the direction of the uterus, then we will be able to rectify this problem. Now coming to the treatment of defective embryo development, we can do a lot by lifestyle modification, cessation of smoking and alcohol, dieting, losing weight by exercise, and also DHEA, an antioxidant, has a great role to play in improving the quality of egg and sperm. We can also select the spermatozoa with minimum DNA fragmentation. There are many techniques to do that. And finally, intracytoplasmic morphologically selected sperm injection, or IMSI, which is a refined ICSI procedure, improves the outcome in cases with recurrent implantation failure, because you are choosing a suitable sperm under magnification and then injecting that particular morphologically healthy sperm inside the egg. Now, there are other treatment we can do in order to improve the quality of embryo. We can do testicular sperm extraction. So rather than having a sperm from the semen, we get it directly from the testicle. We can do pre-implantation genetic screening to identify if the embryo is healthy or not, although there is a little bit of controversy in it. And finally, comparative genomic hybridization, or CGH, which will identify the detailed characterization of the blastocyst. So we can select a very healthy embryo before transfer. Now, the other aspects of improving the embryo quality is by assisted hatching. We can do blastocyst transfer. Most of us are now doing blastocyst transfer because it gives us better embryo selection, better synchronization between the embryo and endometrium, resulting in better implantation rate. So it's worth doing blastocyst transfer in cases of recurrent implantation failure, provided it wasn't done in the earlier attempts. Now, an age-old technique called ZIFT, which is not popular anymore, that is zygote intrafallopian transfer, like GIFT, gamete intrafallopian transfer. We did it nearly 25-30 years back when I was training in UK. Now, ZIFT is like putting the embryo in the fallopian tube where the embryo actually develops, and whenever it is appropriate, embryo will travel inside the uterine cavity and implantation is better. Now, it is not practical and not widely used because it needs laparoscopy, which is an invasive technique. Now, finally, we can also do co-culture or ooplasm transfer, and at the end, if you cannot get good embryo, you may use ovum or sperm from donors. That is something we do as a last resort. Now, how do we improve the endometrial receptivity? We can remove the structural problem like fibroid, polyp, septum and adhesion, and nowadays we do it very easily with the help of hysteroscopic procedure. If there is infection, endometritis, it needs treatment, and tuberculosis is one of the infections which is common in this part of subcontinent. We treat this patient and then we go ahead with the next attempt, and the success rate is better. One big problem with RIF is thin endometrium. Now, there have been different medicines which we have tried. Sildenafil, modified long protocol with exogenous estrogen, luteal support with GnRH agonist, endometrial perfusion with granulocyte colony stimulating factor, and now we are doing platelet-rich plasma transfusion inside the endometrium. The other way of improving endometrial receptivity is by treating hydrosalpinges. We know the fluid within the fallopian tube can come inside the uterine cavity. Endometriosis is a problem where the whole environment is hostile. If we pre-treat this patient with GnRH analog for 3 cycles, the success rate is better. Sometimes what we do, we collect the egg, fertilize the egg, and keep the embryo frozen by vitrification, and then give GnRH analog suppression for 3 months before doing frozen embryo transfer. Because if we initially suppress with GnRH analog, it may suppress the ovarian function and we may not get eggs in good number. In addition, problems like adenomyosis, endometrioma, they cause problem. They need to be treated either medically or surgically. And finally, polycystic ovary is a problem where the quality of the embryo and the quality of the endometrium both are affected. So we need to treat this patient by weight loss, lifestyle modification. We use insulin sensitizers like metformin to improve the quality of the egg and the quality of the embryo. One recent method has come up, which is called endometrial scratching. That is to put a catheter inside the endometrium in the luteal phase of the cycle before. So 7 days prior to the onset of menstruation, this procedure can be done. We do it for 2 purposes. One, it helps us like a dummy embryo transfer to identify the direction of the cervix, and we scratch the lining of the endometrium. The jury is still out. Many papers, many randomized controlled trial have shown definitely it is not 100% proven benefit. Some studies are showing benefit. In my opinion, we can try this, at least it doesn't do any harm. Now, there are many other empirical ways of attempting to improve endometrial receptivity. One is intravenous immunoglobulin, aspirin, heparin, intralipid, no definite evidence. Modified stimulation protocol, again not proven. Administration of recombinant LIF prior to embryo transfer. Granulocyte colony stimulating factor, gene therapy, endometrial reconstruction with stem cell, which your president is a leader in this field, using stem cell for the endometrium as well as for the ovary. And finally, if the endometrium is really not receptive, then we may have to do a surrogacy. Now, coming to the embryo transfer technique, all of us are now doing ultrasound guided transfer. I've said repeatedly there has to be a trial embryo transfer or a dummy embryo transfer, particularly if there is a previous difficult transfer. Now, I do a dummy transfer in each and every patient, and if I find difficulty, I will do a hysteroscopy, I will dilate the cervix before actually going through the IVF cycle. Some people have suggested we need to aspirate the cervical mucus, although it's not universally proven. Now, sequential embryo transfer is something like we transfer a day 3 embryo or maybe 2 day 3 embryo and then a blastocyst. So there's a very high risk of multiple pregnancy, so many people are hesitant to do that, but perhaps 1 day 3 embryo and 1 day 5 embryo will be good because it helps in identifying the implantation window. Maybe if we transfer at 2 different times, at least one of the embryo will be in the right implantation window time. And I've already mentioned ZIFT is a technique, although not very practical. Now, in order to identify implantation window, we need to individualize every patient. And we need to find the appropriate embryo transfer time according to their response. So, according to the endometrial response in the dummy cycle, we decide when to transfer. Okay. So, in other words, the implantation failure could be, it's a failure of timing of implantation in otherwise normal endometrium. So, if the endometrium is most suitable on day 19, we are transferring on day 17 or day 21. So, maybe it's premature or post-mature, and this is what we are identifying very much either by ultrasonography or by endometrial receptivity array or ERA. And in future, secretomics of the endometrial fluid will help us to identify the most appropriate time of the embryo transfer so that there is best synchronization between the embryo and the endometrium. Ultrasonography, you can look at the pattern, you can look at the myometrial contraction, echogenicity, grayscale, blood flow, several things we can do. But the most effective way is to look at the endometrial thickness and endometrial receptivity by blood flow. Endometrial receptivity array, we take an endometrial biopsy on day 21 or 5 days after a progesterone replacement in an HRT cycle, or day 7 after the HCG injection. And from this endometrial sample, we extract RNA, and the expression of 238 genes are analyzed, and it tells us whether it was premature or post-mature on that particular cycle. So if it was premature, we need to transfer it late. If it was post-mature, we need to transfer it earlier by day 1 or day 2. So in conclusion, RIF is a hurdle race. It is a big challenge in ART, and as a matter of fact, it is the main bottleneck for a successful assisted reproduction treatment. Counseling and supporting plays a very important role, and this is what we call TLC, tender loving care. Because unless we counsel our patient, explain our patient, and reassure them, they're not going to come back for the treatment. And many a time we learn from their experiences, from their individual responses, and we can rectify the treatment provided they come back. There has to be some form of treatment or reward system to improve the immunological balance. And there are many research going in that field using steroids and using dydrogesterone. Now, one thing one must realize is there has to be a realistic expectation of the pregnancy rate. Now, sometimes patients expect 100% implantation. That is not possible. And with the increasing problem, the success rate lowers. So one has to understand, it is like having a dialysis or chemotherapy. You actually need many attempts of treatment, and we have to counsel our patient even before starting the first attempt. If we tell them the first attempt is going to be successful, they are not going to come back for the second, third, or fourth attempt. Finally, it is very important to take a second opinion. Encourage your patients to go and see someone in the same city or other city, so that their confidence develops, and maybe the second person is going to suggest some form of treatment which is going to help the patient. What we need to understand, majority of these patients are idiopathic. So no matter what you do, it may not happen, and only few treatment options are truly beneficial. So finally, I would say only patience will lead to success. And I will end my talk with a small experience which is like this. A patient came to me after having 11 attempts elsewhere, and she conceived on the 4th attempt in my clinic. So she actually succeeded on the 15th attempt. It is true that majority of our patients do not have this amount of perseverance, this amount of confidence, or this amount of their physical and financial capacity to go on. But I'm sure with the improvement in science, most of our patients are going to get pregnant within 3, 4, 5, or maximum 6 attempts. Thank you very much for your patient hearing. Thank you once again.
Ma'am, unmute yourself, please.
So we thank Dr. Gautam for his very detailed and very scholarly talk on recurrent implantation failures. There are no questions in these sessions, and we move on to the next speaker. May we invite Dr. Nandita Palshetkar to present her talk on low ovarian reserve.
I'd like to thank Dr. Sunita Tandulwadkar, President of the POGS, and Amit Patki for giving me this opportunity. My talk today is on poor ovarian response. And poor ovarian response, I think the new classification is Poseidon Group 1 and 2, which is young patients where the ovarian reserve tests are normal, but they give a poor response. And Poseidon Group 2 is where they're older patients, more than 35 years, the reserve is normal, but it's an unexpected poor response. And the Group 3 and the Group 4 are those patients where the ovarian reserve tests are low, they're definitely, we expect a poor response. And the group 3 are the younger ones under 35, and the group 4 is above 35. The management is actually based on the fact that in a woman, the biological age is very, very important. If a woman is between 35 to 37 years of age, 5 eggs give 1 euploid embryo. And as she ages, you can see in the slide that if she's more than 42 years old, more than 20 oocytes are required to give 1 normal embryo. And that is the aim of poor responders, that depending on the age, that is the number of eggs that we require to give 1 baby to these patients. And therefore, if you look at the slide, the PGTA, it becomes very, very important when you do pre-implantation genetic diagnosis, because the minute you get a euploid embryo in a patient who's even 40 years old, she becomes like a 28-year-old and gives you a pregnancy rate of 60 to 70 years old. So using technology in this group of patients is really, really helpful. And maximizing ovarian response, how do you do it? Normally, what we do in poor responders is high dose of gonadotropins. You use HMG, you use highly purified products, or you use recombinant. All are equally good. Protocols which we can use is antagonist, mild stimulation, long antagonist protocols. These 3 are the commonly used protocols, and they give equally good results. What do I do in my personal practice? I use the antagonist protocol, the mild stimulation protocol. In a few patients, I also do the dual stimulation. That is, do 2 stimulations in 1 cycle. And of course, do embryo pooling for these patients. That means do at least 3 or 4 ovarian stimulations, do 3 or 4 ovum pickups, pool the embryos together, and then start doing the embryo transfers. And use a dual trigger in poor responders, definitely, because that gives me better oocyte retrieval in these patients. What are the adjuvants that I use? For poor responders, we definitely use adjuvants. Though the mechanism of these adjuvants is uncertain, it is speculated that the DHA and the testosterone increases the IGF-1 concentration, which may improve the response to gonadotropins. It improves steroidogenesis as a precursor for estradiol and testosterone. It creates a PCOS-like characteristics and increases the LH. It acts as a pre-hormone for follicular fluid testosterone, reduces age-related aneuploidy by affecting the meiotic chromosomal segregation, and increases the small antral follicles and the AMH levels. So what are the adjuvants that are used in our practice? The DHEA, the dose is 75 milligrams per day. It should ideally be given for 3 months before starting the stimulation, and I continue it right up to the patient gets pregnant. The side effects are acne, which can be troublesome, and then the patient has to stop it, or if any change in voice. Testosterone is another adjuvant which I use. I use it for about a month prior to stimulation. Growth hormone, I use it during stimulation, or you can also use it 1 month prior to stimulation in a dose of 4 international units daily. Or during stimulation, you can use 8 international units during the stimulation. Coenzyme Q is an antioxidant, which is also helpful in poor responders. 300 IU is the dose. Melatonin also gives me good quality embryos. I use it at the dose of 3 milligrams per day or 4 milligrams per day. L-arginine is a nitric oxide donor, good antioxidant, is also used. I also use it in my poor responders. An estradiol pre-treatment for 10 days, 4 milligrams per day, from day 21 of your previous cycle, actually sees that the cohort of follicles that are achieved when you use antagonist treatment is really very, it's uniform. The growth is very synchronous, and it really helps in poor responders. When you get oocytes in these poor responders, I think various technologies can be used to get the best results out of this very less genetic material which you've obtained, the poloscope. Because if you have 2 or 3 eggs, there is a 20% chance of the spindle being damaged when you perform ICSI. So you can use the poloscope technology in preventing damage to that spindle or the DNA. Then you can use embryoscope to identify which are the embryos with the best potential for implantation. And nowadays, there are algorithms which tell you about the aneuploidy of the embryos also. And of course, PGTA. PGTA is, as I mentioned before, it will tell you about the euploidy of the embryo, whether the embryo is normal or not. And NICS is non-invasive chromosome testing. As you can see in the diagram which I have put, that the culture media in which the blastocyst is growing is actually taken. It's subjected to Malbac technology, and then with the help of NGS platform, you can actually identify the chromosomes which are there in the embryo. And if the embryo is euploid, this embryo can be used to give a pregnancy rate which is 60 to 70%. So in a poor responder with very limited genetic material, if you get a euploid embryo much earlier, her problems are solved. So these are different technologies which we can use to give a poor responder a better pregnancy rate and a faster time to pregnancy, definitely. New opportunities that have arisen in poor ovarian reserve. You have in vitro activation of follicles. You have rejuvenation of the oocyte which comes, especially in older patients, which is autologous as well as heterologous. Then you have artificial ovary. You can create an artificial ovary and you have creation of gametes. So let's go through it one by one. So ovarian rejuvenation. There are really new opportunities for ovarian rescue in women with POR by different strategies focused on the rescue of the existing follicles. So even if there is POR, there are existing follicles in the cortex which are there. So you can do it in different ways. In vitro activation. So you can do it by the tissue mechanical fragmentation, that is by disrupting the hippo pathway, and also in those patients which have already had failure, you can add the PIK3 enhancer and the PTEN inhibitor so that the dormant cells are activated and proliferated. And of course, there is stem cell activation as shown by Sonia Herasa and in the Pellicer unit in Spain, the EV unit, where she has injected the stem cells into the ovary, and pregnancies have been obtained. And of course, we are also doing the intra-ovarian PRP injections. We're doing a multicentric trial where we are injecting PRP into the ovaries and then doing stimulation. In fact, recently I read an article where the PRP was injected and 1 year later that ovary has started producing eggs. So these are all the technologies which are available today to rejuvenate the ovary. The ovarian rejuvenation can be heterologous and homologous. Homologous is using your own, the oocyte rejuvenation, sorry. So when you're using your own, so supposing this is an egg which is aged. So there is a technology called the augment technology. Here the mitochondria are taken and they are increased, they are cloned kind of. And then when you inject the sperm into that oocyte, the extra mitochondria, the cloned mitochondria are put inside. So the energy is doubled in that same oocyte. So autologous rejuvenation is done. Whereas heterologous rejuvenation is what Nuno Costas did in 2019, where he took the nuclear material from an old oocyte and put it into a donor oocyte, and he achieved a pregnancy. But these technologies are expensive, and there are ethical problems with heterologous because of three DNAs, three different sources of DNAs in it. So they are not yet popular. So what are the different technologies for artificial ovary? Alloderm is a decellularized human extracellular tissue matrix used commonly by the plastic surgeons. But Octi has used it to create an artificial ovary. So what he has done is he's taken the primordial follicles from patients who've had cancer and have had their ovaries removed. And these ovaries, the primordial follicles are removed and put on this decellularized matrix, and an artificial ovary has been created. And this has been put back into the, by laparoscope, into the ovarian fossa, and 2 pregnancies have been obtained. And Susan Pors, in 2019, when I heard her talk, she's created again artificial ovary using alloderm, and has really by 3D printing of the ovary. So these are different technologies that can be, in future, which look very promising to the poor ovarian reserve patient. And of course, the final frontier is the gamete production. We know that the stem cells have the potency to differentiate into oocyte-like cells, but these can also cure female reproductive disorders once they are transplanted into diseased models. However, we are yet to create a fully functional oocyte. Best sources from where to create the ovarian tissue derived cells, and so the best sources are ovarian tissue derived cells and very small embryonic like stem cells. In fact, there's very good research from our own ICMR lab in Bombay by Dr. Deepa Bharti. And in fact, I have seen in a lecture the follicles growing and the follicles being aspirated in hysterectomized specimens of the ovaries, which she has done in menopausal women. So it's very, very promising, and we are really looking forward to a fantastic era where oocytes will actually be produced, and these hapless patients will not have to go for oocyte donation. So finally, to conclude, I think stage 1 and stage 2 patients, remember there's something new that has come into the treatment. You can increase the dose, you can add LH to these patients, because Poseidon 1 and Poseidon 2, you need to do precision medicine. You can do genetic testing of these patients, and you will find defects in the FSH gene, in the NOBOX gene, in the AMET gene. And these will tell you that some of the patients, sometimes they have a poor quality of oocytes, they have fragile eggs, and they have poor fertilization rates. And these patients would rather, I have a patient today, which I was counseling, and she said, I will do multiple pickups because she is young, she's 33, and I want to have a baby which is of my own eggs. I'm willing to do it. See, once they know what is the problem, they are then willing to try it again and again. So I think in Poseidon 1 and 2, it's worth doing a genetic test of these patients. And in Poseidon 3 and 4, the adjuvants will work beautifully. And the long protocol and the antagonist protocol and the duostim and the dual triggers will work beautifully. But remember, with the duostim, you have to use the GnRH analog trigger, because the HCG trigger is a long-lasting trigger. So the dual trigger has to be used in duostim. I know this was a short talk, so I tried to pack in a lot, but I would really like to give some take-home messages. Adjuvants play an important role. Give the dual trigger prior to oocyte retrieval if it's not a duostim. ICSI and IVF results are same, but I use ICSI. Offer PGTA to older patients. We are offering it in all our POR patients. And future looks promising, where the need for oocyte donor may be eliminated completely. Once again, I would like to thank the POGS for inviting me here today. Thank you, Sunita. Thank you very much.
Thank you, Dr. Nandita, for this very crisp and beautiful presentation on low ovarian reserve. We move on to our next speaker, Dr. Amit Patki. Dr. Amit is live, I think. He's going to speak on a growing problem which we encounter in practice, that is obesity and ART. Over to you, Dr. Amit.
Thank you so much, Sabrina, and it's a pleasure seeing all of you virtually. And I congratulate Sunita and Sarita for putting up such an excellent program. And as usual, Pooja, who has been of immense help in doing the background work. I hope you all can see my slides. And yes, are my slides seen?
Yes.
Yes, sir. Thank you.
Yes.
Very good afternoon, and I'm sorry I couldn't join at the beginning of the workshop. As you all know, Pune and Mumbai is going through the thongs and mayhem of COVID, so I was a little busy trying to organize for some of my colleagues' bed in the hospital. What is also more worrying is about obesity. It is also growing very fast. It is almost becoming like a global endemic problem. But what is obesity and how does it impact reproduction? Obesity is characterized by an abnormal or excessive body fat accumulation to the point at which it becomes harmful to one's health. So obviously there is an imbalance between energy intake, which is high, and energy output, which is low. And this is primarily because of intake of foods that are low in nutrients, high in calories, and along with that, a sedentary lifestyle. And basically this is the leading cause for obesity. Now, how big is this problem? In 2014, nearly 2 billion adults were overweight throughout the world. And of these, 600 million were obese, almost coming to around 30% of them. And we all know that it is a major public health issue problems. But how does it affect reproduction? Obesity is known to have wide-ranging impact on the hormonal milieu, and consequently, it is the chief factor for anovulatory infertility, for irregular menses, even for early miscarriages, preterm deliveries, and various other pregnancy complications. Now, how do we classify obesity? This is the classic classification where we classify according to the BMI, but understand that in the Indian subcontinent, the qualifying BMIs are 2 points lower than the standards for Caucasians. That is, the overweight is cutoff is 23 and not 25. And this is something we must understand. I think it is very important in the infertility clinic that we take their height, weight, do their BMIs, and put it right on the top of the paper so we know in which classification these patients are going to be. Most people ask me, in our country, is this obesity relevant? We talk about starvation deaths, we talk about malnutrition, but believe me, almost the global prevalence of PCOS is 116 million women worldwide. And surprisingly and shocking, over a third of our adolescent girls can be classified as PCOS in India. And remember that rates of PCOS are very high where there is obesity and type 2 diabetes, which both are there in our country. And that's the reason we all are seeing a large number of PCO girls, and the number and the percentage is only rising. And the genotype phenotype classification, most of our PCO patients are the obese classic phenotype patients having insulin resistance which is found in over 75% of our PCOS, including the lean, thin PCO patients. So what are the specific concerns as regarding obesity and infertility? This is a beautiful review article which is titled as Obesity as a Disruptor of the Female Fertility. And this clearly says that in obese women, not only that they come with menstrual dysfunctions and anovulation and infertility, but in pregnancy, they also come up with various different problems, including gestational diabetes, preeclampsias, IUGRs, preterm deliveries. And what I think is extremely important for us is to make the patient aware that problems of PCO and obesity do not end at childbearing. It continues ahead. They need to be under surveillance, under supervision, and some of them under treatment to avoid landing up into the metabolic X syndrome with high incidence of diabetes, hypertension, and cardiovascular problems. So the problem is this adipocyte function. This adipocyte cell is one that gives rise to dyslipidemias, gives rise to hypertension, gives rise to arthrogenesis, secretion of adipokines, which is increase in leptin, resistance, decrease in adiponectin, inflammatory reactions, and that's why in obese people, implantation failures are also known, thrombophilias, diabetes, and also unopposed estrogen functions can later on have a carcinogenic activity also in the woman. So it is the visceral fat which is the root cause for cardiovascular disease, and in this it is the insulin resistance, the inflammatory reactions, the thrombogenic events leading to dyslipidemias, hypertension, and type 2 diabetes. So the visceral fat contributes more to obesity than the subcutaneous fat. This has an increased lipolytic response to catecholamines, gives you increased free fatty acid delivery to the liver, so the liver is impaired insulin clearance, leading to insulin resistance. Abdominal obesity causes insulin resistance. This will cause compensatory hyperinsulinemia to maintain the blood sugar, so your pancreas are overworking. This hyperinsulinemia will have action on the ovarian steroidogenesis, increase androgen production by the ovarian theca cells, premature follicular atrasias, leading on to anovulation or scanty ovulation or oligo-ovulation. So we know that this excess weight, excess carbohydrate intake, sedentary lifestyle, and partly genetic is going to cause problems for insulin resistance. What we can do with the patient is to make her aware of diet, exercise, and weight loss. These are the three mantras we should be telling them at each and every consultations that they do with us. Obesity comorbidities are depression because of low self-image, decreased quality of life because of the sedentary nature, deranged lipid profiles, deranged GTTs, cardiovascular problems, and a large amount of anxiety. Psychological investigations are also necessary in these PCO patients, and I think a PCO patient seen in the infertility clinic needs to have a multidisciplinary, having a dietitian, a nutritionist, an endocrinologist, and also will need a psychological counseling. But what happens when you actually treat these obese or these overweight women? They have an increased gonadotrophin dosage consumption, because follicular recruitment requires a particular FSH level which needs to be exceeded to have recruitment of the follicle. The absorption, metabolism, and clearance of these gonadotrophins, which are injected subcutaneously, is altered, and that is why in the obese overweight patients it is better to give them gonadotrophins intramuscular because that is the way the absorption will get better, and because of the increased BMI, we need to give them a higher dose. Higher intrafollicular leptin levels will have an inhibitory effect on this FSH stimulated steroid synthesis by these granulosa cells. So basically, high leptin levels even in the follicular fluid, which is inhibitory to the FSH, you need to pump in more amount of gonadotrophins to get the same response in an obese patient. So a higher dose and sometimes a longer period of stimulation, all leading to an impaired embryo development. The insulin-induced suppression of this hepatic sex hormone binding globulin reduces gonadotrophin secretion because of increased production of estrogen, conversion of these androgens by the adipose aromatase. So you need to give a higher dose because the estrogen production is also high. Obese women will exhibit reduced early follicular LH amplitudes, and it is accompanied by prolonged follicular genesis and diminished luteal progesterone levels. So you need to give gonadotrophins for a larger dose, a longer period. You need to get a good ALH level, which may not happen in these patients. And more important is you need to give a good progesterone support because they have an inadequate luteal progesterone levels. What happens in the morbidly obese PCO patients? The peak estrogen concentrations are lower, you get fewer oocytes, impaired fertilizations, fewer embryo formation. As I said that you need to give higher doses in gonadotrophins, but the problem is that even if you get oocytes, the oocytes are of poor quality. They are smaller size oocytes, although they are mature, and these lead on to a lower fertilization rates, thereby giving you a less number of good quality embryos. So women with a BMI of more than 25 have smaller oocytes that are less likely to complete development of fertilizations, and quite a large number of these embryos are arrested even before the blastocyst stage because they contain more triglycerides than those which are normal embryos going to blastocyst. Blastocysts which are developed from oocytes of high BMI, I said, are smaller, contain less amount of cellular materials, lower glucose consumption, altered amino acid metabolism as compared to embryos from normal weight women. And that is why if you see in your practice, obese PCOs will sometimes give you large numbers but won't give you the good quality eggs, thereby giving you poor fertilizations. So obese people are less likely to achieve clinical pregnancy after IVF and embryo transfer, and adding to that, higher rate of miscarriage and low live birth rates. As I said, because of the inflammatory reaction, they have an impaired endometrial receptivity pattern, and people have done studies and found that the endometrial gene expression during implantation in these obese women is different from the lean women, and that is why they also have a decreased implantation. Looking at this miscarriage rates, if you look at an overweight woman, the odds ratio for miscarriage is 1.29. When you go into the obese category, the odds ratio goes up to 1.7, and the very obese, the odds ratio is 2.1, which translates that the very obese have 2 times higher risk of having a miscarriage than a woman who is normal BMI. This is a very good presentation of one slide which shows a higher miscarriage rates in PCO women which are long down regulated for IVF ICSI. The higher miscarriage rate is not related to oocyte morphology, embryo quality, or even to the high-tech test that you do for developmental and metabolic activity, but is clearly related to the BMI. You reduce the BMI and you will get better eggs, better fertilizations, and better take-home babies. So management options have been always been lifestyle, use of letrose or even extended letrose, gonadotrophins alone or in combination with letrose. Orlistat can be given to obese women who cannot do the first part of diet and exercise. Adjuvants like metformin and myo-inositol and combination of metformin myo really works very well in the obese group. And the last is the bariatric surgery. So when I talk of weight loss, we see that when women are in the BMI of 30 to 35, the outcome in ART is reduced by 30%. And when women are in the BMI of more than 35, the outcome in ART is reduced by 50%. So this is the relative risk as compared to BMIs. You find that as the BMI goes up, the risk of infertility is increased.
Sorry to interview, sir. 1 minute left, sir.
Yeah. So you tell your patients that if the BMI is increased by 1, the odds ratio to getting pregnant is reduced by 0.8. And if they reduce their BMI by 1, the odds ratio is increased by 1.1, which translates into 5 to 8%. Now this weight loss has to be a modest weight loss. We don't want crash diets. We don't want crash weight loss, because crash weight loss will in fact is detrimental and will give you still further poor egg quality. It has to be over a period of 3 to 6 months. What are the caveats? As I said, no short-term caveats, no crash diet. It has to be spread. You can use metformin and myo-inositols. As I said, Orlistat can be used, although it has got some side effects, and Orlistat needs to be stopped when the woman gets pregnant. The British Fertility Society says that they do not offer ART to obese women until they have lost a particular amount of weight. Bariatric surgery indicated in BMIs of more than 40 or in BMIs of more than 35 with coexisting medical problems, but you have to wait for 18 to 20 months to have the ART done after bariatric surgery, so that the micronutrient loss that has taken place is adjusted. The best thing for women trying for a pregnancy is gastric banding, because these bands can be released in pregnancy. Thereby the patient can eat well, the child grows well, and you have very little chance of IUGR. This is a fantastic guide for assessment and management, a joint effort of ESHRE, ASRM and Monash University. And my take-home messages are: the obesity is universal, sedentary lifestyle, food habits are the most important causes, will affect folliculogenesis, egg quality and endometrial receptivity, has a high risk of miscarriage and pregnancy complications. But lifestyle is something that we need to tell the patient. Every visit we need to not only counsel the patient, the husband, or even the family members. Insulin sensitizers play an excellent role. Bariatric surgery is to be reserved for the severely morbid obese patients. Thank you very much. And I also want to thank Sunita for that excellent memento that has reached us. And I think this is a fantastic memento. Thank you, Sunita. And this is something that I'm going to keep right in the center of my consulting room, because it's a very beautifully done memento. So thank you very much. And thank you to all the listeners for a patient hearing.
Thank you, Amit. And I'm so glad you received that in time. And I'm happy that you will be keeping it. I also know that you and your wife had a debate whether to keep at home or at the clinic.
Not a debate. Whenever most of the mementos go to my clinic, when this arrived in the house, she said, "It's so beautiful. Do you want to take it, or we could actually find a place in the house?" So I was surprised that she wanted to keep it in the house and not pack it off and send it. So really, thank you very much. I mean it.
Thank you. Thank you. Sabrina, you are muted.
Sunita, thank you for inviting me. Thank you, Sarita and Sunita. It was really a pleasure.
Thank you to all the speakers. You all have made this session very vibrant and interesting. Lovely. Moving on.
These are all with S, starting with S. The names.
Stars, no? This is a star conference.
And Amit, you people have done that session such a justice, you know. The passion, I don't know who was more passionate, whether it was Rishikesh or Nandita or Amit. Absolutely amazing session we had. And thank you, Sarita and Amit, for putting up such a wonderful workshop. Thank you once again.
So we move to the last and final and best part of this workshop. It is said that each star is a mirror reflecting the truth inside you. So we have a star set up now for our panel discussion, which is moderated by none other than our eminent past president, Foxy, and infertility specialist, Dr. Rishma Pai. And she has got only stars in her brigade, starting with our very own host and president, POGS, Dr. Sunita Tandurwadkar, Dr. Parikshit Tank, Dr. Prakash Trivedi, Dr. Padmarekha Jirge, Dr. Madhuri Patil, and Dr. Sujata Kar. Please, Dr. Rishma, over to you. I can't wait for this to begin.
Pregnancy happens. So today, you're still worried when you have missed out your monthly periods. I, Dr. Subesh Nare, I'm going to talk about...
Ma'am, you're mute. Yeah.
Sorry, good afternoon. Good afternoon to everybody. Thank you. I think even though it's mid-afternoon siesta time, everyone looks nice and bright over here. And Sunita, you're amazing. I never thought you'll be able to make a quick trip to the hospital, do the pickup and come back in time. So truly amazed at you.
I'm juggling in 4 workshops at a time.
Yes.
There's so much parallel going on. Yeah.
Okay, give me just half a second while I share my screen with all of you. All right. So can I be seen and heard now?
Very well.
Thank you. So when I was preparing this panel just 2 days ago, and as usual, you thought you'd put in all your references and, you'll give all the latest updates and everything. And then I actually went back and saw the lists of panelists, and I realized that it's such a star-studded panel that I have to do nothing. In fact, I would be being very unfair if I were to talk and allow these amazing panelists to not have enough opportunity. And so it's going to be one of the simplest panels I've ever done, basically because, So starting with 1978, when it all began, Sir Robert Edwards and Steptoe's work resulted in the first IVF baby, Lucy Brown. She was born in 1978 in Greater Manchester. And you can see how the family has progressed. Lucy Brown has her own baby now, naturally conceived. But Lucy herself, she was conceived after hundreds of embryo transfers done at that clinic. They were natural cycles, no ovarian stimulation was done, and pregnancy rates were truly dismal. But then to now, more than 40 years ago, and millions of IVF babies later, we are still struggling to achieve success in many different situations. Every now and then there are new changes, new recommendations, and of course, single pregnancy, no pregnancy, multiple pregnancies. Each one of them sometimes creates a problem for us. Recurrent miscarriages, implantation failures, surgical problems, diseases, all of them again are very, very difficult to deal with. And so really looking forward to some very practical tips from all our STAR panelists today. It's only befitting in a STAR conference, you should have a STAR panel. So let's begin by saying that when faced with a challenge, look for a way, not for a way out. And all of you today, I know, have found these ways to tackle these different difficult situations. So let me begin with a standard patient. You see it every day in your clinic. Mrs. K, a 33-year-old, 2 years of infertility, married for 5 years, but didn't plan for the first 3 years. HSA was normal. Wife's routine tests were normal. Her HSG showed one side slow spill with a small hydrosalpinx and the other tube was normal. No laparoscopy done. This patient I have literally seen 2 days ago when I sat down to make this presentation. And so she was really fresh in my mind and I was quite agitated after talking to her because discovered now, 2 months ago, AMH 0.2. She came to me after having failed 4 IUIs. Please note, AMH was not done. This was with a leading obstetrician gynecologist from South Mumbai. Not an ART specialist, but a leading OBGYN in South Mumbai. 4 IUIs failed. FSH, LH, E2 done at least 5 times when I saw the reports. I was scrolling through them. LH was 2 to 3 times the FSH value. And so she was labeled as a PCOS patient and IUI upon IUI was being done. So this is a real patient. 2 days ago, I've seen her, frustrated me, but I want to ask you all, should we do AMH as a routine for all women after marriage or whenever they come to you first so that they can make a reproduction plan? Is there something like a reproduction plan? Do you advise it? This is my first question, and I'm happy for anybody to take that question because all of us feel very strongly about certain things,
So I think what I feel is all of us do a baseline scan whenever a patient comes to us. So if we see that the antral follicular count is normal, probably we could skip doing AMH, but at any point we find that the patient is a PCOS, that is she has multiple small follicles or she has less number of follicles. I think AMH should be done in this group of patients because it's going to help us to guide what treatment we need to offer to them.
What is your resistance to doing an AMH for, she's married actually 5 years. Supposing after 2 years of marriage, she'd come to you for euphoria, anything, she's not planning a baby. Why would you not tell her to do an AMH and so that she could plan, maybe she wants to plan after 3 years. You say, okay, let's do an AMH, let's find out and you can plan later. Why resist AMH?
AMH also, but I think an antral follicular count gives equal information. So if we find that the antral follicular count is normal, I don't think an AMH would be required, according to me. If we find she has less number of follicles or we find she's a PCOS, then probably we should do AMH because that would guide us to what treatment we need to offer.
Even for me, AMH is not a routine test I would advise women unless they have certain reasons like age is more than 35 or 33 or 34. She has had previous ovarian surgeries, or she has any evidence of endometriosis. Otherwise, this is not a routine test.
So this lady, and I think she's one amongst many we have seen, did not have any surgery before this. She had nothing. She was a normal girl, didn't want to have babies. 3 years she planned. Now when she started, all this started coming up. And, so this is a real life patient. And so next question, whoever's taking answer, my next question is well. Is there a role... Sorry, if I may just finish this question and please answer this for me. Is there a role for FSH, LH monitoring during ovulation induction? She was doing IUI and multiple times LH, FSH, E2 was done for her. So please, Dr. Trivedi, you were answering whatever you wanted.
No, what I want to endorse is there are clear evidence to suggest that AFC is superior to AMH in meta-analysis. AFC is a good marker. Like you are telling, in last 15 days, we must have had 0.2, 0.4, 0.6.
Absolutely.
And there are a host of low AMHs. Obviously, AFC is superior to AMH to predict the response. But I think so we have to, if you ask the first question, bottom line is you do AFC and there is no disadvantage in doing AMH because, sometimes the patient comes and disappears.
Yes.
It will come after 6 months. So I think so you have to have your own protocol. But sometimes you are shocked with so much low AMHs at 20, 30 and so on.
Yeah.
Also, the assays are very unreliable.
Anybody has any logic why?
Can I add something, please?
Yeah, Sunita.
See, what is important is Madhuri or Sujata are saying what are they doing in their practice. So if they are doing sonography, they found 7 to 8 follicles on both sides, they feel no need of AMH. Here what is important is to give a message to the people who have joined as a delegate. They are OBGYN and they may not have the sonography machine next to their cabin. So the AMH, if you feel so, 33 years lady, 4-5 years not getting pregnancy, and if you are not doing your own sonography, AMH please is mandatory because no radiologist will tell you antral follicular count correctly. And as Reshma said, even if she is not planning, she comes for any other purpose, she says, I want to plan 2 years down the line, I have a habit of saying her, please do AMH, and if AMH permits, then only. And to our surprises, we find AMH so poor. There are so many patients who come only for a couple coming for a preconceptional counseling. Shockingly, you see only 2 follicles. You do AMH, it is 0.6, and they have come for preconceptional counseling, and here instead of just giving your folic acid, you are taking them in a totally different spectra. Very difficult to counsel. Please go for ART to those women who come for preconceptional.
Routine checking. No, like I said, being a real life case, I want to ask you why. Of course, this particular doctor, because they're not an IVF person, was sending for semen, preparations also outside. So the semen prep was coming from outside. Sonography was being done, and obviously all of this was missed. So in this particular patient, had they known there was such a low AMH, LH was 3 times the FSH values, I don't know why, and one side tube was not very good. So should IUI have been done at all, or they should have been advised a little earlier to go for IVF? Now that she's come to me for IVF with an AMH of 2, as it is, the prognosis is pretty poor,
I think we need to take into consideration all the factors. And there was no need basically to do FSH and LH every cycle. It's more important that they should have monitored ovulation induction, and when we are monitoring the ovulation induction, we would really know that what the antral follicular count was and basically how many follicles were growing. And if the tube also was compromised, and I think she had failed 2 or 3 IUI cycles, she should have been advised IVF immediately.
Yeah, I think so. We would have at least been able to give her a slightly better prognosis. Anyway, currently, you can't say anything negative about a doctor. So we didn't say anything. We said, fine, no problem, we'll deal with it. So today now she is a poor responder. She's been stamped as a poor responder. What is the best stimulation protocol for her? Today, what can we do for her to improve her and give her the best possible outcomes? Now she has high LH, FSH is normal, AMH is 0.2. I don't have the AFC because nowhere was the AFC written. Follicle studies were done, but AFC was never written. In the follicle study, she was growing an egg. So what is the best stimulation protocol for this lady? If you want to just age and everything, she's 33 and totally trying for 2 years, married since 5 years totally.
Okay, let us take one by one. First of all, this couple has to be counseled very clearly that since it is the first time, we are trying to take out your eggs. With 0.2, the number of egg and the quality of egg, we are not sure. Secondly, we might have to tell them for a multiple egg retrieval or pulling of the eggs. Very, very important to tell. If after the first pickup, if we find that egg quality is absolutely not good, because we know that even if the younger age, if AMH is poor, the egg quality also is poor, or ultimately getting embryos in hand is very poor. The success rate with you will be very, very low. Second important thing is about the stimulation protocol. What I do in my practice is after one pickup, I sit with them after the before the first pickup, this all counseling goes. You may need one more, two more pickup, we don't know. You may need a third party option, we don't know. I do counsel because after DCGI for the stem cells, which is also still a research. So it's absolutely clearly explained to them. And then only after you do one egg retrieval, how she responded, what are the quality of eggs and what are the quality of embryos you got into hand, you take a call. In this case, she had query tube, query hydrosalping. So you may not think of doing a fresh transfer also. As far as stimulation protocol is concerned, I still believe in doing mini long down regulation protocol than the antagonist protocol. My experience is mini long down regulation doesn't down regulate the ovary, but whatever 3-4 follicles you are going to get it, they are of a same cohort. So probably you don't land up in a cancellation of the cycle or too many different kind of eggs in one at the time of a pickup. You have more or less same cohort. About the dual stimulation, I work in an institution. Every stimulation costs to the patient equal. So if it is 1.2 lakh she has to pay, I might as well take another cycle with 3 months gap than the dual stimulation in my setup.
So I want to ask, does anybody actually practice or has practiced dual stimulation? Because we do know one thing. Sunita, I agree with you that the costs are high in an institution. But if you want to bring her back after 3 months, then her AMH is going to be completely, almost zero maybe.
I don't think so, Reshma. I will give her maybe her BMI reduction, the little bit DHEA time. Yeah. And you never know, after 3 months, you will have a more or less similar up again. So I don't think, and frankly speaking, I tried dual stimulation, and second time I did not. How the one is getting, and after listening to him, after going through his paper, I did try, and I realized I would have got better number of eggs and quality of eggs if I would have taken.
So does anybody have any experience with dual stimulation?
Yeah, no, I have done it only in fertility preservation, but not for poor ovarian reserve. I've done it in 1 or 2 patients, and I found that it wasn't really of much help. And what I feel is doing a fresh transfer in a patient of poor ovarian reserve gives better results than freezing them, because anyway when we are freezing them, we are subjecting it to stress, and again when you are thawing. So I prefer doing a fresh transfer, especially in a patient who has a low ovarian reserve, because probably the chances of pregnancy are much better.
So you don't believe also in oocyte pooling or embryo pooling? You don't
as long as I have 1 or 2 good embryos, I believe in transferring those embryos, because we also need to look at what happens to the embryos when we freeze and thaw them. And I think they are more susceptible to cryo injury, especially if it's from a patient with low ovarian reserve, because the oocyte quality also many a times is compromised in this group of patients.
So, yes, please, Dr. Devi.
Yeah, Reshma, 2 important points, and Sunita brought out that we are extending this entire session to common gynec and so many others. Now, I have 5 sonography machines. Yesterday, I ordered 2 more sonography machines. So the take-home message for common practitioner is, if you're doing PV, if you're not having TVS, you are back to 1996. So either you have a sonologist or you have somebody in your own setup, and even if you're not doing yours, so seriously everybody has to have sonography machine and sonologists in their own center. Second is, lots of patients we had, as I told you, in recent time with very low AMH, was standard after everything what Sunita told, we explained to them. And we do explain to them that we are going to do 2 months prior, enhancing your response. So we do either PRP or stem cell in the oocyte. We give an androgen gel in the previous cycle, and then take them up and then we were shocked. One patient, in fact, from Pune, at 41 years with 0.4, 0.6 AMH, when we stimulated, she got 18 oocytes.
Wow.
We had 15 embryos, and they were originally from South Africa. So in their happiness, she also conceived, fortunately, spontaneously. Fortunately, I had told that at 41 there are higher chances of abortion, and 9 weeks fetal heart disappeared.
Yeah.
So we did a termination, but we still have 15 embryos. So I think so priming or enhancing on the existing AMH for 1 or 2 months with various methods is a boon.
And this is before the first cycle or after the first cycle doesn't give you good eggs? This patient may have given you good eggs right at the beginning.
Yeah,
so what is your opinion or advice to others? If I see a very low AMH and low AFC, should I advise or counsel the patient directly to do maybe PRP or stem cells?
No, basically what I'm trying to tell is we have to give, say, for example, androgen gel. We have to tell them,
yes,
prepare your ovary for a better response for your 0.2 AMH or 0.3 AMH. And this example was pretty surprising.
Yeah.
So at least you can anticipate or patient understand we are not directly jumping onto stimulation and the dual stimulation, etc. and all. So actually what happens is they feel, okay, this becomes more scientific. And of late we are finding that the response with this is much better. Of course, you can't get miracle like 18 oocytes, but that's the fact which is just in 4 months back.
So for the people who are listening in, and since we didn't discuss it, I just want to give a very, very brief thing about double stimulation, because we spoke about it in poor responders, because sometimes you don't have much time, or if the patient is going to go for chemotherapy or something like that, you can do 2 cycles at one time. You can do your normal follicular stimulation from day 2, get the eggs out after giving an antagonist and a GnRH analog trigger, get your eggs out, and a few days later you can restart the stimulation in the luteal phase, because now it is known that there are waves of oocytes in the ovary, and you can actually catch the luteal wave and you can actually stimulate. And many studies have said that you get equal number of eggs in the follicular phase and in the luteal phase. I think most of us are quite new to this, and that is why we haven't got that experience. If we do it more often, we've started doing it, we haven't done too many, but if we do more of these cycles, I think we will also get that kind of expertise. And a little bit,
moreover, it has also been shown in many studies that the cohort of eggs what we get in the second stimulation, that is in the luteal phase stimulation, is almost same as what you get in the follicular phase. And the embryo quality also is good. And the pregnancy rates are almost similar in the luteal phase as well as the follicular phase stimulation.
Exactly. So it looks very encouraging. As far as this is the stimulation, what about the trigger? Anybody believes in dual trigger? Because these are all new things. So I want you to talk about them so that everybody realizes how much has changed even in simple stimulation protocols. So especially for poor responders, and now even for normal responders, there is suggestion of double stimulation. Parikshit has just joined us straight from the airport. Welcome, Parikshit.
Thank you.
And you can take that double trigger. Do you believe in that?
No, we don't really practice this. Either we go with HCG, which is like the gold standard, but in certain situations where safety and prevention of OHSS is a concern, then of course one would use an agonist trigger in an antagonist cycle only.
Responders. So in a poor responder specifically.
So
I think dual trigger basically is when you get both GnRH agonist and the HCG together, and it's basically indicated in those patients who have a low ovarian reserve or who have had previous poor response, or wherein you've had poor follicular oocyte output ratio, and where your fertilization was not good or embryogenesis was not good. Whereas a double trigger is wherein you give GnRH agonist at 40 hours before oocyte retrieval and you give HCG at 34 hours before oocyte retrieval. So that's the difference between a dual and a double trigger. Yeah.
But essentially what I'm saying, there are again many studies to document this, recent studies, that if you give, for example, 10,000 units of HCG along with 0.2 triptorelin, that is a GnRH analog, in poor responder patients, you might get better quality, quantity of embryos, mature eggs, and better maybe pregnancy outcomes. And these are minor modifications that we can make. So I think this is something that we could do. So again, I have a patient, I'm actually doing egg freezing. I had advised her, and on stimulation, she started to grow only one egg. So it was 16 millimeter, one single follicle. Of course, this patient is egg freezing, wasn't looking for pregnancy. So my question again with these poor responders, when you get only one egg which is undergoing stimulation, what do? Abort or continue the cycle? I'll tell you what I did. I stopped the cycle. I didn't continue. I mean, what is this girl going to do? What is her future? So, yeah.
But you need to continue because you're not sure whether next time you're going to have that one egg also developing or not. So
I agree with you.
As a poor ovarian reserve, I think whatever we get, we should. And at least if we do the aspiration, we would at least know the oocyte quality. So then it will help us in counseling her later, whether she can go with her eggs or she requires oocyte donation. Or we can still try another cycle of IVF for her.
I agree with you. That is my opinion. So the whole cost of the pickup, admission, anesthesia. Yeah. So there's a whole added cost, and when you can't guarantee them that one follicle will give one egg, it becomes very difficult to adjust that. So
I think what matters is the intention going forward. If this couple has an intention that okay, we'll cancel now, save money, and then go for an egg donor, then that's fine. They can cancel it off.
Yes.
But if they are not going for an egg donor anyways, ever, then fine. I mean, let's continue and see what happens.
You get whatever the best.
Reshma,
yes.
I had heard one very competent ART consultant who I will not name, but who was very sure that even one follicle and that one embryo is not less.
Yes.
So I would have done what you are telling, but after hearing this gentleman,
I agree.
I started realizing that there may be a scope wherein you clearly explain if you get something you are lucky, but if you don't get, you frankly tell it is not worth transferring.
And you also know nowadays it is very strongly suggested that if we are doing what I said, for example, start stimulating the patient, get one egg or don't get any egg, you can in the same cycle switch to a donor cycle. So same cycle can be converted into an egg donation cycle. Patient's endometrium is getting prepared. You can borrow those oocytes, do the sperm injection with the husband and transfer in the same cycle. So that is also a possibility with many of these recent studies are telling us. So last question for poor responders, and we go ahead because otherwise we can talk forever on poor responders. Only if you have one embryo or two embryos, would you all like to do pre-implantation genetic testing? So grow to blastocyst first of all or not, and do PGT or not?
Reshma, can I say something? I will not go for a blastocyst at all, because we also know that we will end up in no transfer. In vivo sometimes may be better than in vitro, and certain fallacies about the PGT. I will not even make it more expensive by advising PGT. I have one embryo, day 3, good quality. I just will do the transfer and leave the destiny to take its own course. If it is a healthy, genetically normal embryo, she will have implantation. If not, then it is not going to be.
So thank you, Sunita. That's a very practical advice you've given us. Unlike what many times the books tell us, one embryo, grow to blastocyst, PGT, put it back. So what you're saying is absolutely practical. Unless somebody wants to have an opposite opinion of that, I think we can go ahead. I think all of us are more realistic and more, sort of on the ground, even about the economics of it. And that's why this is
because in India, the ART cycles are sponsored from their own pockets.
Yeah.
So we need to be more practical in every decision what we give or what we do for the patients.
Absolutely. So I think we got quite a few practical tips. Dr. Trivedi already spoke about androgel. I think that is a role to play. DHEAs, these there may be some role to play. Coenzyme Q10, some of the studies have said. Growth hormone, some of the studies have said. They may have a small role to play in ovarian, improving the ovarian reserve, in other words. So now let's go to the other side of the spectrum. We have Mr. S, is the 34-year-old male, recently married, and on a routine checkup when they started planning, found that he has azoospermia. It came as a shock because there was no medical illness, nothing to suggest that he would have azoospermia. All basic tests, sonography normal. Wife has not been investigated too much because suddenly the husband in the beginning itself was found with azoospermia. So wife has been kind of left alone, overall normal. And now what do we do? So after the shock has set in, now they want a solution. So what further test in the husband after he has been on 2 tests shown to have azoospermia? Who wants to come in? The male expert. The 2 men in our group.
Yes, maybe I'll start and then Sir can take it from there. So the most basic test that I would advise the husband is an FSH. To determine, what kind of potential are we looking at in terms of testicular function.
FSH was high. Let's start with that. FSH was
okay. So let's 25. Say the FSH was 25 or something, and in that case, I would talk to them about the potential reasons. I mean, it's probably a testicular failure in some form.
Why don't you think of doing a clinical examination also?
Yeah, assessment.
Yeah, I mean, that would go hand in hand.
You need to identify whether it's a non-obstructive or an obstructive.
Since you
started with an FSH of 25, I think it's...
No, but then you need to do clinical examination. If you find the testicular size is normal, then there are chances that you can get sperms. But many a times when we find that the testis is totally atrophic, there are no chances. Even if you have a lower FSI that's 15 to 20. So I think once you examine, you need to go clinical examination and then go in for hormonal
volume. So assess testicular volume. FSH is already suggesting testicular failure. So the other question is genetics. That aspect most of us never address in the male. So I want somebody to tell me what is the 1 or 2 maybe or no genetic test that you want to do in this man.
In case we are going for TISA, I feel we should do Y deletion because if you have C type of deletion, then only we can get sperms if you do a testicular biopsy. But when we have A and B, there are no chances of getting any sperms. And if the male partner has a deletion, we need to counsel them that if they have a more male progeny, there's always a chance that that male progeny will have the same defect and would have infertility, and so they need to take a decision on whether they want to go ahead or they want to do a sex selection to select a female so that there is no defect.
Is that allowed?
That's not allowed.
Yeah, it's not allowed in India, but elsewhere it is allowed. But as this is a case wherein you can, because there are several diseases where you have X-linked diseases, wherein you can still do sex selection because the patient has got X-linked diseases.
With permission.
Rishma, can I just add something?
What I say is, it is not only for azoospermia, even for a severe oligospermia is very, very important.
So what I have gathered is only Y deletion is the only test. Anything else genetically or anything else we need to look at?
In case you have bilateral obstruction of the vas, you can do CFTR gene analysis because it has been associated with.
Small point.
Yes, yes, Dr. Trivedi.
Yeah, see, what happens is, fortunately, because of COQ and so many talks in male infertility, one of the biggest thing is there are so many ART practitioners who are female, which is a credit. But what happens is nobody wants to examine scrotum of some other man.
I agree.
So it's a practical thing that you should have a male assistant who is at least used to palpating. Because I do a lot of examination, but with compulsion. I'm more than happy to examine a female rather than male. But a female will not bother. So I think so a practical suggestion is, I used to discuss with 2 of my andrologists, and that is what used to be a practice. That's a small practical point.
I agree. Most of us won't examine the man. So we need
Rishma, can I just add something?
Yes, Sujata's
been since just a practical pointer, because your question was if you see azoospermia, what to do next.
Yes.
So my set of things is once you've confirmed it 2 times, then I have a set of tests that I write to the patient. First is andrology consultation. The next is FSH, LH, TSH, prolactin, total testosterone. I don't know if everybody will agree or not. And the third is scrotal Doppler. So this is the set that I write for them. And then they go and come back. Because sometimes even examination, the andrologist also may not be very sure about the testicular volume and things like that. So this is a set that I write once I see azoospermia.
And this will pretty much give us the entire information that we require. So now you have a patient of testicular failure. any role for medical therapy and, directly biopsy the husband. And when we're doing the biopsy, this is often a dilemma for us. Should we do ovarian stimulation on the wife simultaneously, or should we tell the wife that you wait, we'll get the sperm. If we get a sperm, then we'll stimulate you. Otherwise, we won't. So what is the way forward? These are practical. Padma, are you tuned in?
Yeah. Can you hear me?
Yes.
Can you hear me? Yeah. So I think, in a scenario where it's a non-obstructive azoospermia, I think the doubts, you have raised are very, very pertinent. Can you hear me, Rishma?
Yes, absolutely.
Yeah. So, whereas if it's an obstructive azoospermia, that the decision is much easier because we know that we will get sperms even if we stimulate the wife and then on the day of retrieval do a simultaneous PISA. But the question you have raised is very, very pertinent. So the way we manage this kind of a scenario is if we can do a TISA and identify sperms, then we would do a trial TISA. But if that doesn't in identifying any sperms, then we have to counsel them for TISA or micro TISA on the day of egg collection with a clear understanding that we may not be able to retrieve any sperms and consequently we may have to freeze the eggs. Yes, there have been efforts to freeze even single sperm, but it's not been a very routine procedure, and the success consequently achieved is not very, very steadfast. So this is what we do normally.
Yeah. Any other opinions on that? So why not now with with a man like this with an FSH of 25, a routine TISA may not give you sperm. So should you not counsel directly for micro
charging?
Agree with you, Rishma, totally. Think about not only the TISA or TISA or micro TISA. Only thing is micro TISA becomes very expensive, especially in my where they have to pay for the machineries, while TISA becomes little simpler. Also, TISA is performed in a, practical aspect what we face is, TISA we do in an IVF complex lab, while for a micro TISA we have to go into the operation theater complex where the microscope and everything is available. So these are the minute, you need a little bit more coordination and the time with the team and the andrologist and yourself. Now, most important thing is don't stimulate the woman. Your question, which was, then you put them in a fix. We need to give them a breathing time. So trial TISA or trial TISA is the one which we always say them. And when we do the trial TISA, if we find in a few tubules we got the sperm, we just stop them. And we decide absolutely whether we need them further or to do the fresh TISA or the frozen one can be used. So
there are pros and cons to that, Sunita, because one, that means you're subjecting the man to two procedures. Had you done a proper micro
procedure again and again for the ovum pickup, how many times she undergoes again and again while husband is just giving the semen by masturbation. So if we are
one man should suffer for the sake of all the other women who have suffered. I agree with you.
No,
let the man suffer.
It is a because oocyte freezing doesn't have as good result as the fresh eggs. So if you have stimulated her and if you don't find it, you just give them 2 hours to think about the mindset, because whatever counseling you do, they always have a hopes, oh, I'm going to get this sperm, I'm going to get this sperm. So I feel it is not psychologically right to put them in a pressure. Allow them to think over, we did not got the sperms, now you give a choice. At the time of egg retrieval, if you give a consent for donor sperm and micro TISA, that time you can afford to do the micro TISA.
Yes. I agree with this completely what Sunita has said. If we are unable to do if we are unable to retrieve sperms through TISA or TISA, if the couple need micro TISA, they have to be given the option of donor sperm, use of donor sperm, before we take them through stimulation.
I think, Rishma, the other important thing is, if you have examined the man and if you find that the testicular size is too small and its consistency is too soft and the FSH is high, we need to tell them that the chance of getting sperms when you're doing a TESE or a micro TESE is very, very less. That's what has to be explained to the patient.
Everybody will counsel. In fact, at 25, I'll tell them from the beginning only.
Everybody will counsel. In this situation, it is a dismal situation. Yeah. But Mansi, the dilemma is this, that if you do the biopsy and you get very few sperms, then on one hand, you're saying that you don't freeze single sperm, right? So if you don't freeze single sperm, you're not even taking the eggs at the same time, then you are just doing multiple procedures. So had we planned from before, told the girl that there's a chance you won't get, but we're still going to freeze your eggs for whatever it's worth, and you all can think in the future. And at the same time, go into the biopsy, get 1 or 2 sperms, freeze sperms, and then do the direct injection. So I think there are pros and cons to everything. It's not easy.
Yes. Can I add a small point?
Yes.
See, with the andrologists, I make it clear because, for example, as Sunita rightly mentioned, see, we may have everything about endoscopy, IVF, etc. So I ask them where you are comfortable. So they will find a hospital wherein they have the OT and their IVF lab close by. Because the transit time also is important.
Yes.
So usually last 2 of similar cases, I told the andrologist, you decide, you inform me which hospital, because then I will evaluate how is the ART of that center. So on that basis, that is the only patient where I tell you go and do it under one roof rather than doing outside.
Yes, yes. Thank you. So a lot of dilemmas here, never straight answers, and that's why this fantastic team of experts' brain is being picked today. So now I totally believe in this. By changing nothing changes. So that's why we are constantly changing, trying to do newer and more different, approaches to patients. So we have this lady, she's 32 years old. She's trying to conceive since her marriage 1.5 years ago. Semen analysis is normal. And Dr. Trivedi is so excited. I can see a smile on his face already. She has a 5 centimeter endometrioma in the left ovary and a 3 centimeter endometrioma on her right ovary. Uterus looks normal. She's not had an endoscopy. They just married 1.5 years. And she actually has almost no symptoms, no significant dysmenorrhea. Whatever she had it from the beginning, some dysmenorrhea. AMH is 1.5. So, Dr. Trivedi, obviously this question is coming to you. What is your approach for this girl?
One major thing about endometriosis, and I would honestly like to tell, that typical laparoscopic surgeon who don't have much of ART background, they excessively do surgery for endometriosis.
Yes.
Things are very clear. If there is no pain, there is no dyspareunia, ideally endometrioma doesn't need surgery. That's point number 1. Second is, if you are doing a surgery, first surgery is the best, and after that you straight away take for ART. Because 1.5 AMH
already 1.5 only.
And third, it is also a good endometriosis surgery, as I was discussing once with Sudha Prasad, transiently improves the AMH because the inflammation is gone. So endometriosis surgery, typically like a laparoscopic surgeon, you don't have to seek, there is a pathology, let me operate, which is the most irrelevant decision we take. So according to me, touch an endometrioma only if you're convinced, because in this patient, there will be 2 technical problems. When you stimulate, she will get follicles. If you ask me, she doesn't need surgery because there's no pain, there's no dysmenorrhea.
So you wouldn't do a surgery, you will start her on IUI or IVF?
I would love to differ and I'm so happy.
Yeah, me too.
I am just waiting for Prakash to complete. I'm very happy.
No, that we want to continue.
I am very happy that you are happy.
I am trying to, I am already leaning towards Dr. Prakash Trivedi's opinion. So Sunita, you'll have to argue very hard to convince me otherwise. Tell me.
Yeah.
Sunita, you're muted. Sunita, you're muted.
No.
There's going on me.
See, I will tell you what. Let's study. She's 32 years, married for 1.5 years only. No surgeries before. Don't get carried away with 1.5 when Prakash himself has said because of her inflammation. I would like to know the staging of the disease. And laparoscopy is not for the surgery of endometrioma. Laparoscopy is to decide the staging. Many times it is just localized into the ovary. You do fantastic laparoscopic surgery. While doing, take care how to conserve as much ovarian tissue as possible. And if the endometriosis is not extended into the pelvis, tube-ovarian relationship is fantastic. Within 6 months of laparoscopic surgery, she can conceive naturally. This is very important that you have to do. So here you are not doing surgery for 3 centimeter endometrioma or 5 centimeter endometrioma. Here you are doing a laparoscopy to decide the staging, to advise her further course of a treatment, and in the same sitting, because you are doing a laparoscopy, you are removing those endometriomas.
That is my question, Sunita. Right in relation to what you're saying. So you are doing an endoscopy because you don't know her tubal status. So just because you have a scope in, are you going to operate both the tube ovaries?
I'm going to operate. That's what
there's a 3 centimeter endometrioma on one side.
No, Reshma. Listen, today it is 3 centimeter, but in no time, I'm not sure whether I'm 6 months I'm going to give her a pregnancy or not. I don't want to remain this endometrioma untouched. Take this out. It is not the only endometrioma. We all know that implantation is affected by the presence of endometriosis. We know that Th1 immunity is going to be higher if there is an endometrioma. So I'm saying I'm not going to directly jump for the IVF in such case, only thinking 1.5. I am seeing 32 years. I am seeing 1.5 years marriage. I don't know what stage of endometriosis she is. So I'm going to put in a laparoscope. I will do the staging. I will counsel the patient. I'll do the video recording. And at the end of a surgery, I will sit and discuss what is your next treatment line. Whether I will allow you natural conception. We all know within 6 months of a laparoscopic surgery, if the end result is good, you will conceive. And if in 6 months you don't conceive, then I'm going directly for an ART for you. I don't then keep on trying with IU and all, because I need to give higher success rate than IUI. So
Sujata, I want to just say something. Sujata, this girl, now Sunita is a really good surgeon and she does a good job, and fortunately patient becomes pregnant with simple treatment in 6 months and she blesses her. On the other hand, I am not such a super fabulous surgeon. I do my best surgery, bilateral endometrioma surgery. I'm a good surgeon, not superb. And her AMH falls to 0.5 after 3 months. Now, what is yours? Are you guaranteeing her that you will not damage her ovary during the surgery? She keeps on bleeding. You do the cyst removal, bleeding. So you have to cauterize. You can't guarantee that, right? AMH falls to 0.5. Whose fault is it? You could have gone ahead and done IVF directly.
No, I wouldn't. I don't think the surgery is ever going to. I don't think my surgery is ever going to lead her AMH to fall from 1.5 to 0.5. That is my. That is how I would counsel. The main thing that I would want to also make the patient understand is that the pain and endometriosis severity, there is usually no connect. Sometimes the patient may have no pain, and yet you might find a very severe disease, even peritoneal and ovarian. So with a bilateral endometrioma, you don't know the status of the pelvis, you don't know the status of the ovary, then the status of the tubes, then what choice do you have? Then I have to ask her to do a IVF straight away. Without a IUI or a,
maybe an HSG,
HSG will tell us nothing, in my opinion, because it will not tell us the tube-ovarian relationship. In any case, in endometriosis, the tubes will be patent. But the tube-ovarian relationship and the pelvis will be totally distorted. So if I see a bilateral endometrioma, I would certainly, and that to a 5 centimeter, which is also going to hamper we can't even do a proper AFC count or, IVF egg collection, I feel. So I would definitely plan a surgery for her. And if her AMH points to 0.5, I wouldn't believe it, frankly, because of surgery that it will fall.
It does. We've seen a lot of patients going into premature.
It takes up to. Reshma, I want to add something. It takes up to 6 months for the AMH.
And usually it bounces back.
So
I agree. I said that, which is why I said 3-4 months later.
Right. So 3 months is too early.
If we don't operate,
topic of a discussion, Reshma, that the first surgery in endometriosis has to be the best surgery, and by the best surgery.
100%.
You really opened up a very important topic or a thought for a discussion.
Reshma, can I add?
Reshma, if we don't do the first step,
Do you think by advising IVF you have a 100% guarantee that you will give her a pregnancy? No.
I agree. So I want to ask everybody here, and if it's very difficult on an online platform for everyone to talk. So if I can have a show of hands, would anybody operate only the big endometrioma and leave the small one untouched?
Reshma, prior to that, can I tell you a European guideline statement?
Yes, I'm aware of it. Tell me.
See, the EDGD guideline, which was in 2013 and again modified. See, the point it is not that when a patient comes to infertility, in older time we used to advise them contraception, danazol, pseudomenopause. Endometriosis is a disease which is not understood. There is classical bilateral cyst. You do a PV, there is no tenderness. Why on the earth she will have too much of endometriosis? You have bad rectovagina. The data clearly suggests, for example, here if you knock out one of the endometriotic cysts, the other ovary is normal, then you can stimulate. So my point is EDG suggests two things, that you don't rush and operate. Point number one, if there is no pain, there is no other pressing thing. Second point number, I agree with Sunita, you can have spontaneous pregnancy rate, and the precise spontaneous pregnancy rate after good surgery, which has been referred by IVF consultant, is 23%. So basically you have to understand, you don't get lost on the endometriosis in infertility patient, and don't get lost on we ignore the pain in endometriosis patient who is not having endometriosis. You cannot mix up because you know endoscopic surgery, you have a rule of thumb. But I don't disagree with what both this female have told. I had intentionally put a statement to make people realize you select and do the best surgery and then take her up for stimulation. And the exact data is 23% spontaneous pregnancy rate. And we had too many times, many ART consultant referring, we have done a surgery and they have a spontaneous pregnancy. But don't keep jumping, because this endometriosis is going to recur after 2 years if she's not pregnant. So I think that is a balance which we have.
It's a very, very hard debate, and which is why I brought it up, because it is tough, these
very happy.
I would like to say that because it's
not only a one person. Sunita, if you can finish, yes. What did you say?
I'm very happy that Prakash agrees of the two female opinions. I really want to say this very important carry-on message, that if the patient never had taken a treatment, for the first time sonography, 1.5 years not becoming pregnant, you saw the endometrioma, don't jump for IVF with AMH of 1.5. But as Prakash said, don't wait for 2 years also, because endometriosis is going to recur. So 6 months of your laparoscopic surgery, no pregnancy, ART should be advised. Secondly is, we all should know, by advising immediate ART doesn't mean you are giving her 100% success. Recurrent IVF failures is a very painful story for such women. Give them a chance for a natural conception with fantastic...
Madhuri, I want to bring you in. Madhuri, a lot of guidelines, international, are saying don't operate endometriomas just because you see. So can you tell us about what some of the guidelines are saying?
Yeah. So what I mean, most of the guidelines say that you need to operate if the patient has pain, or you feel that it's going to come in the way when you're doing a oocyte pickup, the endometrioma. And even for grade 1 and 2, the guidelines say that if you're doing a surgery for any other reason, and if you see, you can probably, coagulate them or excise them, and then stimulate them with gonadotropins and advise an IUI, because this increases the pregnancy rate by almost threefold. And when it comes to grade 3 and 4 endometriosis, there have been so many patients, I myself have had, who had got spontaneous pregnancy also, despite having grade 3 and 4 endometriomas and endometriosis. But if the AMH is borderline, you can go for ART. But what I feel is, if this patient is married only for 1.5 years, we do HSG under the C-arm, and which is which gives you at every point of time, and it also tells you about the tubo-ovarian relationship. It also gives you idea if there are any adhesions between the tube and the ovaries. And I think that should be the first investigation. And if we find that there is a compromise, there is a terminal disease, there are pelvic adhesions which are seen when you're doing HSG under the fluoroscopic control, probably then, and if the patient wants to try on her own, then I think surgery should be done. But if she doesn't want to try, then if she says that the tubes are patent, I would like to go for IUI for 2 cycles and then for ART, I don't think the endometrioma needs.
I think ASHRAE guidelines say that any endometrioma more than 3 to 5 centimeters should be the first time.
That used to be earlier, I think. Most of the latest.
Now the recent one doesn't say that. The recent guidelines.
So what Madhuri is saying is the patient who's for IVF.
Yes.
Who has a recurrent.
No, I don't think she goes for no. The recent guidelines are saying that no endometrioma should be operated only if the patient has stage, or you feel that you're going to do an ART and the endometrioma is going to come in the way of. That are the recent
what I wanted to bring up today about practical approaches and some of the guidelines which are a little bit different from what we've been practicing.
A very important point.
Yes, the last word, Dr. Trivedi, on this particular subject.
What today afternoon only, I had a patient from Baroda. Her sister is a laparoscopic surgeon in Delhi, general surgeon. So she had her endometriotic surgery done there, which I believe was done properly. After that, some ART consultant told you, okay, we'll take you up for ART, gave 6 months 11.25 depot.
Oh God.
Then they stimulated, and I could see that the endometrium was thin, over suppressed. They got good blastocysts. They transferred. Now today when I saw her, she's having 4 centimeter adenomyoma.
Oh dear.
So now her AMH is 2.39. What I'm trying to tell is real life practical scenarios are different. Because sometimes patient get convinced, okay, I'll remove my endometrium, I'm going to be beneficial. And then they go to ART, they say, no, you don't worry, we'll do an ART. So now she's kept for adenomyomectomy in the next cycle, next week. But what I'm trying to tell is endometriosis and adenomyosis, it's a complex subject. And what we have discussed till so far is very practical and very relevant.
The other thing,
Rita, you have to tell me how much time I have, because if I can take one more case.
Rita, one more thing.
A little late, yes.
Reshma, I wanted to tell us, initially it was thought that when we gave depot GnRH agonist for 3 months prior to ART, we had a better outcome. But the most recent studies have shown that whether you use an antagonist or you use a long depot preparation, the results are almost same. So that's the other point, because many of us still probably think that we need to give depot preparations for 3 ultra-long.
Now you have to mute yourself, please, Padma. Please mute yourself. Yeah. Thank you. So we'll take one last question, I think, because we started quite late. The conference was running late. So Mrs. N, she's a 28-year-old, married 2 years, known case of PCOS with delayed menstrual cycles, obesity, BMI 32, hirsutism, everything. Classic PCOS. AMH is 9. Again, something we see often in our clinic. AFC is very high. HSG is normal. Husband semen normal. Taken 2 cycles of clomiphene and letrozole, not ovulated, which is again quite typical of some of these PCOS patients. Just don't respond to CC or letrozole. So what next? Wait for weight loss. We just heard Amit Patki, so we shouldn't talk about weight loss. She's obviously tried and failed, loses and gains weight. Metformin, I think most people would recommend. How do we go forward in this girl? Stimulation protocol, any surgical interventions? What do we do?
I think, the choice is whether to make her ovulate and have a conception with IUI or planned intercourse versus doing assisted reproduction. These are the 2 broad pathways at a certain point.
But she has a normal HSG, so we are not really talking ART right now. Just cycles of CT letrozole have failed.
Yeah, why I brought in ART at this point is that you might
somebody needs to mute their
hello.
So much disturbance. Can you please mute?
Hello.
Yeah, Parikshit, we can hear you.
Sorry, the reason why I brought in ART so early into the discussion is that we might land up in a situation where we intended to do a mild or a gonadotropin stimulation, which was supposed to generate only 1, 2, 3 at the most oocytes, but inevitably we are going to have situations with these kind of women where you may have 6, 7, 9, 10. So that's why we need to keep ART somewhere high up in the hierarchy of choices that we are going to offer.
So tell me your protocol. 2 cycles of CC and then
I'm
what
not
will you
going
do?
to talk about the oral agents, so on and so forth, and neither am I going to touch upon drilling, because I don't think it's worth doing a laparoscopy for this woman. I would usually start off with about 50 to 75 units of recombinant FSH, and then give it for 5 to 7 days, do an
With or without letrozole or clomiphene?
no letrozole. If she's not ovulated with letrozole in the past, I don't see value in doing that.
Okay.
So day 2 or day 3, and then start with low dose FSH. Wait for 5 to 7 days, do a scan, see if the endometrium is thickening up, whether we are recruiting a follicle or not. If she's not, then from 50 to 75, go to 100, 125 units. Again, spend about 5 to 7 days there, and then, if at that point, if she's not, then theoretically one could keep going in that manner, but at some point you'll have to call it a day and stop.
Yes.
So typically I wouldn't run the stimulation beyond 10 to 14 days.
Rishma, one important point, Parikshit. See this currently, for example, weight loss, it is so easy. For example, I have lost 16 kg 3-4 times. I have made people lose. Now, the important point is we have to counsel the patient, okay, look, it is not just pregnancy, because you may have higher abortion rate, as Abdel Gadi told, 8%. What we have to inform them, okay, we are going to take you scientifically for a stimulation protocol. Only if you just follow for 2-3 months, 2.5 to 3 kg weight loss for 2 months. Once you tell them, and you tell that you can easily lose 18 kg, because nobody has told them. So when you tell, you give the diet, you give entire thing, and tell after 2 months we'll do whatever is planned, and you will have higher chances of pregnancy and less chances of abortion. 8 out of 10% will stay with you because you have written and you have explained lifestyle changes and diet taking half an hour. Means if I have explained, or Aditi has explained, or somebody else has explained, that does wonders, and a lot of patients don't need ART also.
Yeah.
Sorry, I didn't mention that because I thought that discussion has already happened.
Yes. No, I agree. So I agree. We went through that because I said Amit just discussed only obesity for 20 minutes, so we didn't need to go on that. But Parikshit, I'm with you. Start with low dose. Go ahead. The problem with the PCOS, as you know, is either they get no eggs or very few eggs, or they get too many eggs. So the counseling for IVF. Any modifications in the trigger that you will make? What is the down regulation?
Always an agonist trigger. Always an agonist trigger.
So always antagonist down regulation, always analog trigger.
Yeah.
No, I interrupt? I don't do that. Probably if her number of follicles, dominant follicles are less, I would always prefer giving a HCG trigger. So my trigger will basically depend upon the E2 values on the day of HCG as well as the number of dominant follicles. So if I don't have E2 value which is more than 3,000, and I have only about 10 to 12 dominant follicles, I would still prefer giving an HCG trigger.
Why would you do that? Why would you take a risk? Because there may be large number of medium-sized follicles.
It will depend on both medium and as well as the dominant follicles. It's not only the dominant follicles.
But
so I
have
many cases of mine have given a HCG trigger, and I don't think I have any problem because I normally stimulate them. I give a minimal stimulation because I don't want many follicles developing. So I prefer in having about 10 to 12 follicles in any patient because I feel that the
low risk of OHSS. Madhuri, I don't think you can be confident and sure that this girl won't get OHSS. You know, I mean, she's a bad
I don't use in all.
I don't know. I think there's a difference of opinion here. Sunita, yeah?
I just want to say my experience over last 6 months. I stopped antagonist completely and I moved on to the progesterone down regulation every 20 milligram, and it's fabulous. In fact, I'm sending my publication now, and we have done nearly, in last 6 months, nearly 75 cases whom we believe, because for a mild responder, I use mini-long protocol. For a normal responder, I still use mini-long protocol. And for a hyper responder, I used to use an antagonist with LH trigger, definitely. And we started using Devery protocol thanks to this pandemic, where we got to read a lot about it, and we confidently went off. And egg quality, embryo quality, nothing compromises, and it's a fantastic and most economical protocol. I request all of you, only thing is ensure that the patient has purchased the Devery tablet, because if she starts menses and she just don't start it, I don't know. I late starting Devery, whether I'm going to.
Which day are you starting? Are you starting along? Sunita, are you starting along with gonadotropins?
On the day of the
gonadotropins.
Yes.
So this is one of the protocols where it is a analog-free protocol. So but you need to explain to the patient that you have to freeze all the embryos, and embryo transfer.
A fresh cycle transfer won't be
Analog free, because I still will be giving a LH trigger. Only down regulation, you are not using analogs.
No, but Western primed, you have to freeze.
This is going to cause a change in your endometrial receptivity. So you need to freeze all the way.
See, otherwise also for hyper responders, I think we all go small protocol. I just give a OCPs, I get a beautiful synchrony of follicles, and Devery protocol is a fabulous protocol to come out with.
I'm glad you brought that up, because we are talking here about newer stimulation strategies.
I'm sorry to interrupt, ma'am. We are in 5 minutes. We can wrap up, please.
Yes,
thank you. Thank you.
We can definitely use medroxyprogesterone from day 2 of the stimulation along with the gonadotropins. Continue it throughout the cycle. It will prevent the LH surge. Then you can give your trigger and you can freeze all the embryos and transfer back in a subsequent cycle. So it's cheaper and it's easier. But the bottom line remains.
Can I, Rishma, I feel that it's pretty new to completely change over. Sunita has got good experience, that's fine. But if you think we are always going and talking about the fact that natural cycle is the best embryo, best egg, best embryo, best endometrium, etc.
Sujata, we've lost you. Have you muted yourself?
No, I think internet problem.
I have one more, again, a little difficult, let's put it as a bit debatable statement to make. Madhuri just said to me that she believes that if you get 10 to 12 eggs, they are the best quality. Too many eggs is equal to bad quality eggs. But you know that today there is a totally new viewpoint. This is done by a study of more than 1 lakh samples, and where they said that whether you have 25 eggs, 30 eggs, the quality of the egg is not impaired. And in fact, you get lot of eggs, lot of embryos for freezing. You can get lot of blastocysts. You can do pre-implantation genetic testing. So most studies, and I'm talking international guidelines, are saying that move towards getting more and more embryos. So you can select the best embryo by pre-implantation genetic and transfer only one beautiful embryo, but you get a beautiful choice.
So, I mean, I have also read that paper, but what I do in my practice is, it's not only for the egg quality, basically, but to keep hyperstimulation at the minimum, I prefer having about 10 to 12 eggs. I stimulate less.
I agree with you. That is standard.
I have also read this paper that says that if you get more number of eggs, the cumulative pregnancy rate is higher. It has also said that it does not affect. But there's another paper also which has come and which says that probably COH can have an effect on the oocyte quality. So it's both ways. Cumulative pregnancy rate is
very large study, more than 1 lakh, 1.25 lakh patients.
I think so.
I think we go to the last question.
Just one small point. See, it is very clear what you told, it's fine. But it's very clear, larger number of oocyte, larger embryo, more aneuploidy. Higher the dose, so there is too much of data to support that. So what you're telling is one paper, which I agree what you're trying to tell, but then there is a debate on that. You can go ahead.
I don't know whether there is.
No, I think there is
aneuploidy and egg number.
No, now that aneuploidy thing is gone, because it was said earlier that with increased number of oocytes, the aneuploidy rate is
always
higher.
That was the belief earlier.
But now,
excuse me, ladies,
it
we are
affect the
overshooting.
mitochondrial function. And basically the cytoplasmic maturity if you have more number of eggs. So,
all right, so if we are overshooting our time, then we will wrap up. We won't discuss the last but very interesting case, but we'll go straight to this lovely lady who inspires us. This is Lucy Brown, the first IVF lady in the world. And I want to really end by saying what all of you have proven today. What we know is a drop. What we don't know is an ocean. So though I had the best brains in the country with me today, a lot of knowledgeable IVF specialists, you still realize the amount of debate and discussion and difference of opinion just goes to show that there's an ocean of knowledge out there which needs to be discovered. So thank you all so much for being
Thank you, Rishma.
It was wonderful. We could have continued for another couple of hours.
Great panel.
Thank you very much.
Congratulations for putting up a very
Thank you.
good program.
Thank you. Bye.
Thank you all for being with us. Thank you, Sunita. We all enjoyed ourselves.
Thank you.
Can we have our
Yes. Now, may I please invite our conveners, Dr. Sarita Balerao and Dr. Amit Patki, would like to felicitate them with the plaque. I think Dr. Amit has already received the plaque. Dr. Sarita?
Yes, and he showed it off also.
Sarita has received it, and I'm really thankful to RCOG West Zone for allowing us to have this wonderful 4 hours of infertility. My team was saying it is a OB/GYN, how can you do it? I said I can't breathe without infertility. Yeah, now little bit. And I'm thankful to RCOG for giving this an opportunity.
Dr. Amit Patki was wanting to give the vote of thanks.
I think Sarita.
Is he around? Yes. Dr.
No,
Amit?
I don't think he's there.
No, I think he has left. Thank you, all of you, for this very vibrant session. I think you would have gone on till 4 o'clock in the morning. Thank you very much. Bye-bye.
We just, our gratitude towards Sarita, the chairperson of West Zone AICC RCOG, and I'm sure she has received it and it must be in her cabin already. Thank you so much, lovely girls.
Thank you. Thank you, Sunita. All the best for the next 2 days. Thank you.
Please join us again tomorrow morning at 9.
Wish was there. Sunita को कोई ना बोल सकता है क्या? Thank you.
Prakash.
Well said.
Thank you, everybody.
Bye.
Thanks.